myself, Dr. Akshar Chugh, and in today's session, we will try to discuss and review the entire of Target Test 3. If you are given this test and if you still not have reviewed it, this would be the perfect time to start to review it. And in this session, I will try my best to give you the concepts which are important in these tests and not just facts. So there will be certain questions that will just be like factual questions, and you will have to memorize it because still there is a very good chunk of questions which are fact based. So that is one thing. But especially in questions which are having medicine, surgery, OBGY, there are lots of concepts. So we will try to decode each and every one of the concepts and hope that you learn a very good number of things from this session. So without any further ado, let's start. So in the first question, so what I would suggest whenever you are approaching any question is, if it's a small question, read the entire question thoroughly in one go. But if it's a longer question, which we'll see in the upcoming questions, if it's a longer question, I want you to first see the options, then see the last line, and then read the entire question. So you will know which keywords to look for. So in this question, it's a short question. So we are given a 32-year-old pregnant woman, chronic hypertension. It means that the hypertension is present before the pregnancy. Presents to the obstetrician's office for a routine prenatal visit. She is managed by methyl dopa for hypertension control. Which adverse effects should the physician monitor during this treatment? Now, first we need to understand what is methyl dopa. So basically, methyl dopa is a sympatholytic drug. It acts on the alpha receptors and it acts as a brake to the sympathetic system, right? So it's a sympathetic blocker. So hypertensive crisis and hyperglycemia, which are both the side effects of sympathetic system, will not be the answer. So we have eliminated two options. Now, hyperkalemia is classically seen with ACE inhibitors and ARBs. So even that will not be a side effect of methyl dopa. Methyl dopa is notorious for causing hemolytic anemia. Along with hemolytic anemia, as it is a sympathetic blocker, it also causes depression and drug-induced lupus. Usually we study drug-induced lupus by the SHIP drugs, but methyl dopa is also one of the drugs which causes drug-induced lupus. So this was a pretty basic and easy question. I think most of you should have gotten it correct. Moving on to the next question. Which of the following disease can be treated with a drug that inhibits the vesicular monoamine transporters, or VMAT? So here we are with four options: Huntington's chorea, mononeuritis multiplex, Parkinson, and Lewy body dementia. Now, what does VMAT do? So any VMAT like valbenazine, tetrabenazine, it will inhibit the synaptic vesicles to fuse with the presynaptic neuron and release the neurotransmitters in the synaptic cleft, right? So in Huntington's chorea, there is dopaminergic activity, right? So we need to break it. So in Huntington's chorea, we will use VMAT inhibitors in order to reduce the dopamine levels in the brain. So answer of this question will be Huntington's chorea. Now, VMAT inhibitors are also used in another condition, which is tardive dyskinesia, which is a chronic side effect of taking antipsychotics. So over there too, we use this vesicular monoamine transporters. Moving on to the next question. Again, it is a pharmacological question. It's a short question. Which ligand activates the GS protein, leading to increased adenylyl cyclase activity and elevated cyclic AMP levels? So here we are given 5-HT1 receptor of serotonin and somatostatin. Now, as we know, these both are the GI subtype. Again, this is something that you need to learn it. There is no like concept behind it. Just one thing, that somatostatin is a neurotransmitter or is a hormone which reduces the activity of other hormones. So it's more logical that it will stimulate the GI subtype. Thromboxane A2 is a prostaglandin analog, and it will work via the IP3 pathway. So the best option here will be option 2, glucagon. Moving on, which prostaglandin analog is not used to conduct MTB? So as we know, latanoprost, it is a topical drug and it is used by ophthalmologists and not by obstetricians, right? So latanoprost is a topical eye drop, which we use in many different conditions, and some of its side effects are heterochroma iridis, hypertrichosis, and cystic macular edema. All these drugs will be used in MTP. Misoprostol is used in the first trimester, whereas dinoprostol and carboprost, they are used in the second trimester. Which of the following statements regarding the mechanism of action of disulfiram is incorrect? Disulfiram inhibits the enzyme aldehyde dehydrogenase, leading to accumulation of aldehyde acetaldehyde in the body. That is completely correct. That is the mechanism of action. Second, acetaldehyde accumulates, results into unpleasant symptoms such as nausea, vomiting, headache when alcohol is consumed. So this is also a true statement. Now, this disulfiram acts as a deterrent, which means it if the person consumes alcohol, when the person is on disulfiram, he will develop the accumulation of acetaldehyde in the body, which is responsible for nausea, vomiting, and headache. So again, so option 2 is correct. Option 3 is disulfiram increases the production of dopamine in the brain, reducing the desire to consume the alcohol. Now that is a false statement. Disulfiram has nothing to do with the dopamine production in the brain. So that is a false statement. Disulfiram therapy is often used as an adjunct in the treatment of alcohol dependence. So we use another drugs like naltrexone, acamprosate for the alcohol dependence, and disulfiram is used in motivated patients. Also, disulfiram is not used in patients who are physically dependent on alcohol. So that is also another contraindication of disulfiram. Also, certain drugs such as metronidazole causes disulfiram-like reaction. Moving on to question 6, which of the following levels of fluorine in water leads to development of dental caries? Now, this is a very important point that fluorine level, reduced amount of fluorine as well as higher amount of fluorine will lead to dental problems and skeletal problems. Now, a reduced amount of fluorine will lead to dental caries, whereas high amount of fluorine will lead to skeletal fluorosis, dental fluorosis, etc. So here we are asked about dental caries. So a low level of fluorine will lead to dental caries, whereas 1.8 will lead to dental fluorosis. 3 to 6 milligram will lead to will again lead to dental problems, whereas more than 10 it will lead to skeletal problems. Which of the following disease is mass prophylaxis more commonly employed than mass treatment? Now, whenever there is an outbreak of any disease, we always want to prevent the disease from happening, such as typhoid, cholera. So these diseases which spread majorly by fecal route, mass prophylaxis is always a better option as compared to mass treatment. Mass treatment is usually done for vector-borne diseases such as lymphatic filariasis, malaria, and onchocerciasis. So here the option will be cholera. Which of the following statement is true regarding the switch from trivalent to bivalent OPV? Now we know that in around 2016, there was a switch from trivalent to bivalent OPV in which we removed the second wild polio virus, WPV2, which was removed because it was associated with vaccine-derived polio virus. So it was removed. The switch included removal of WPV1. No, it is WPV2. The reason for the switch was eradication of WP3 in September 2015. No, it was WP2. So this option is correct. Bivalent OPV contains 1 and 3 variant and not 2. Also, the IPV was introduced much before the elimination of wild polio virus 2. So that will also be incorrect. So the correct option is option 3. Great. Moving on to question 9, which of the following are true regarding the components of the given apparatus except? So basically here there was an image of the Horrocks apparatus, and in Horrocks apparatus there would be 1 black cup and 6 white cups. The 6 white cups would be 200 ml capacity each. The indicator used would be starch iodide. and it has one glass stirring rod. Now here all of the options seems correct. So if I were at your place, I would start to eliminate the options. So basically, as we know, there would be one black cup and 6 white cups. So, and this fact was also shown on the figure, right? So you could easily eliminate this option. Also, the 6 white cups of 200 ml capacity each, it was also evident from the photograph which was given. So again, we will eliminate this option. The indicator used is starch iodide, and it is one glass stirring rod. Now, if we think about this question logically, as we know that in each glass, we have different concentrations of iodine and water. So if only one glass stirrer is used for every glass, it will be transferring the iodine from one container, from one glass cup to the another glass cup. So it will be involved in some deficiency in the result. So as a result, there will be 7 glass rod, 1 glass rod for each of the cup. So in this way, you can come to the right answer by eliminating the wrong ones and using logic and common sense. Again, question 10, it was again a graphical based question in which a demographic cycle was shown. So it was an easy question. So if the image is there, you could easily identify that the correct answer was option 2. As we don't have the image, we cannot discuss about this answer. But it was a quite doable and quite easy question. If you have any doubts, you can ask in the live chat. I will try to answer it. So this again is a slightly longer question. Here we are asked which of the following is true regarding the vaccination protocols in pregnancy. So 25-year-old primary gravida in her second month of pregnancy has come to you for a routine antenatal checkup. On further questioning, you will find out that she has not been given any vaccinations yet. Which of the following is true? Okay. So as we know, we give the TD dose. First dose is given during her first visit, and the second dose is given 4 weeks after it, which is 28 days after it. So let's read the options. A booster dose of TD is enough for this patient. A booster would have been enough if the patient has already taken TD 3 years back during her previous pregnancy. But here we are suggested that the patient is a primary gravida, hence booster will not be enough. 3 doses of TD vaccine must be given. No, we can give 2 doses and that would be enough. So again, this is wrong. First dose should be given as soon as possible. Yes, that is the correct statement. Second dose should be given 48 days. No, it should be given after 28 days. So option 3 would be the correct option. Right. Which approach is emphasized under the Anemia Mukt Bharat initiative to combat anemia? Providing free healthcare to pregnant women, it would be considered under the maternal programs. Conducting nationwide health camps? No. Implementing iron and folic acid? Yes, that would be the most obvious answer, right? And distributing hygiene kits in the rural areas. So again, that is not a part under the anemia Mukt Bharat. So this was a quite logical one. Even if you didn't know which one was involved, you can easily find iron and folic acid and anemia, and you can solve the question by just using some common sense and logic. What program is the given image a logo for? So basically the image was an inverted triangle and it was showing a father, a mother and a kid, right? So it is basically a logo for a National Family Welfare Program. So basically again, this is a factual questions. I would highly recommend that you guys have a compilation of all the images possible, which includes the PSM logos, the different types of graphs and charts in physiology. And as we know, the paper style is more about like image and video based now. It would really come in handy in the last mile. So you should definitely like compile images, especially from subjects which are image heavy like micro, PSM, etc., and make a compilation and review it in the last week of your preparation. Moving on, which of the following diseases exclusively involves obligate host in the transmission cycle? So as we know that for any disease to get transmitted, it requires various hosts, vectors, right? So sleeping sickness, hydatid disease, and filaria will involve an array of hosts and also a lots of vectors. For example, in hydrated human is a accident host, right? So measles is the only disease which only involves the host. Measles does not have a vector. It is spread by the airborne route, right? In mountainous region, many residents suffer from endemic goiter. Which type of association best describes the relationship between living at high altitudes and prevalence of goiter? Now, this is a very important concept. So basically, we will dissect all the options. So first, let's start from the multifactorial causation. So, for example, any disease such as genetics, food, dietary habits, exercise, all of these factors will play a role in causation of diabetes. One-to-one causal relationship is pretty rare to find in which only one particular risk factor is associated with one disease. So it is pretty rare to find. Generally, it is seen in infective diseases, but also in case of infective diseases, the environment also depends a lot and not just an agent. The answer of this question is interestingly indirect association. Now, living at high altitudes doesn't directly suggest that you will have goiter, but living at high altitudes means that there will be less iodine in the salt and that there will be less iodine in the soil overall. So the less iodine is responsible for the goiter and not living at high altitude. So if some person is living at high altitude and he consumes iodide salt, then again there will be no goiter. So it is a classical example of indirect association. Moving on to the next question. During the COVID-19 pandemic, airports implemented temperature screening and rapid antigen test for the passengers. This approach is an example of which type of public health screening. So this is the textbook definition of prospective screening. In prospective screening, the patient is not screened for himself or herself, but the patient is screened for to prevent the transmission of the disease to others. Another very good example is screening the blood in the blood bank for HIV, syphilis, RPR, and like other reagents like malaria, etc. So in this, the answer would be prospective screening. A mother brings her 10-month-old daughter to the clinic with complaints of refusal to feed, vomiting everything in the past 2 days. On examination, she is lethargic. Now, lethargic is a buzzword. Lethargic means that the patient is not having oral feeds, and the patient is, it clearly shows CNS depression. She also has fever. According to the IMNCI color grading, how should the child be classified? So this is a severe disease. So the child should be classified as pink disease. Remember, there is no red category in the IMNCI. It is just green, yellow, and pink, which resembles the severe disease. Moving on to the next question, a 31-year-old male who wants to set up a radio diagnostic center consults you regarding the possible health hazards the radio technicians might face. What is the minimum thickness of lead aprons you advise him to provide to his employees to prevent them from radiation hazard? Again, this is a very factual question. The answer of it is 0.5 mm. So basically, lead prevents the ionizing radiation to reach the body. And usually there is an apron, there is a thing which goes around the neck to prevent the thyroid, because thyroid, as we know, papillary cancer of thyroid, the risk is most with the radiation exposure. Moving on to the next question, following disease can be spread by mosquitoes as shown in the image given below. So here the image was provided of a Culex mosquito and it was showing a hunchback appearance. Now, as we know that malaria is spread by the Anopheles mosquito, which lies at an angle from the body. If this is the body surface, at this angle, the mosquito will sit. Whereas filaria is spread by the Culex mosquito, and here it shows a hunchback. Whereas chikungunya and yellow fever, they are spread by the Aedes mosquito, which is a striped mosquito. So here the answer would be filariasis. Also, in a smart approach, you could eliminate chikungunya and yellow fever both, because both of them are by the Aedes mosquito, and like both of them cannot be the answer. So you can easily rule out option 3 and option 4. A patient presents with, okay, now this is again a clinical long stem question. So first we'll read the last line. Which of the following is the most appropriate initial management? That is what we are asked. And from the options, we can gather that the question might be of gout. A patient presents with fever, red and tender swollen left knee joint. Now, knee again does not suggest gout, but in like the polyarthritic stage of gout, even knee joints can be involved. But knee is classically involved in pseudo gout. Let's read further. We started 2 days ago. He's recently diagnosed with hypertension and started chlorothiazide. Now, again, chlorothiazide is a risk factor for gout as it increases the uric acid level. Also, chlorothiazide will increase the lipid levels like triglycerides and LDL. There is a similar question coming up about chlorothiazide side effects on the lipid profile that we will see in the upcoming slides. Immediate joint aspiration is done and microscopic picture is given below. The picture basically showed needle-like birefringent crystals. So as we know that needle-like negatively birefringent crystals are classical of gout, whereas rhomboid-shaped positively birefringent crystals are seen in CPPD or pseudo-gout, in which there is deposition in the knee joint. Which of the following is the most appropriate initial management? Now from the options you can see almost all the drugs are used in gout. But here we are asked the initial management. So every time the first initial management is by NSAIDs. Whereas in case of chronic gout, we use other agents such as febuxostat, which inhibits the production of uric acid by inhibiting the enzyme xanthine oxidase, and probenecid sulfenpyrazone, right? They all are used in chronic gout. In acute gout, the first will remain NSAIDs. Next, if NSAIDs are not tolerated or if it does not produce desired results, then we will move to colchicine. And if colchicine is also not effective, then we will go for intra-arterial steroid injection, right? Corticosteroids. So this is the basic management for acute gout. So here the answer would be NSAIDs, which is probenecid. Also important point I want to discuss here that two NSAIDs are contraindicated in gout, or rather not used in gout. The first is aspirin and the second is paracetamol. So basically paracetamol lacks the anti-inflammatory property. So that is the reason that it is not used in acute gout, where we want to suppress the inflammation. And aspirin, it itself causes a rise in uric acid levels. So also aspirin is contraindicated in presentation of acute gout. Moving on to the 21st question. Again, this is a long question. What we are asked is which of the following statement is true in this scenario? Now let's see what we are given. A health survey reported 5 confirmed cases of CKD in a community of 100 people in the month of December. By the end of January, 3 new cases were diagnosed. Prevalence was reported for December and January, particularly on January 31st, which means January end. Which of the following statement is true in this scenario? Okay, so let's first calculate the point prevalence and the period prevalence. So the point prevalence in December would be 5. The point prevalence in January would be 8. As like on 31st of January, there were 3 new cases, and the 5 older cases would also be there on 31st of January. And the period prevalence from December to January, it also will be 8. Now here's the thing I want you guys to understand, that in case of infectious disease or disease of a shorter duration, the point prevalence and the period prevalence will not be the same, because as the diseases are increasing in the population, there would also be a set of people who are recovering from the disease. But in case of chronic disease such as CKD, diabetes, hypertension, we always find the older group of people to continue in the future. So the period prevalence and the point prevalence in case of such diseases would be the same. I hope you got my point. So the point prevalence is equal to the period prevalence. I hope this is clear. If anyone has any doubt, you can ask in the live chat. I would love to explain again. Just mention the question number in which you are facing the doubt. Moving on to the next question. So this is a match the column, and these are the best kind of questions because if you can match like one or two options, you can arrive at the answer. So here we are asked about cross-sectional, ecological, descriptive, and analytical studies. So we know that in ecological studies, population is a unit of study. So that we already know. So B is 4. So already option 2 and option 3 are out, right? Then in cross-sectional study, we take a snapshot. So we will be able to see the prevalence of the disease. So A is 2. And by that, we are already at our answer. Next, continuing descriptive study and analytical study. So at any time when we want to do a study, we will do a descriptive study in the first phase, and we will do a analytical study later to prove our hypothesis. So analytical study is done for testing our hypothesis or proving our hypothesis, and the descriptive study is done in the first phase of the epidemiology. So first we do case series. First we do case reports, then we do case series, and then we do descriptive studies. And then at the apex, we do the analytical studies, the observational studies, meta-analysis, systematic review, meta-analysis, right? Moving on, a 32-year-old woman with regular menstrual cycle is curious about the number of eggs she has lost since puberty. How many eggs has she utilized through menstruation if she attained menarche at the age of 12? So it is a less of a medicine question and more of a math question. The only learning point is that in each cycle, she will lose one egg. If we are asked number of follicles, it will be far more follicles, but the number of eggs lost will be one in each cycle. So we basically need to calculate how many cycles of menstruation she has undergone. So right now she is 32 and her menarche started at the age of 12. So basically, she has been menstruating since 20 years, and each year she would be having 13 cycles, right? So basically, there are 12 months, but the number of cycles a female undergoes is 30. This, I think you might also be knowing from the Pearl index calculation, which we do. So if we take into considering the months, we divide it by 12. But if we take into consideration the number of cycles, we divide it by 30, because one cycle is of 28 days and 1 month is of 30 to 31 days, right? So we just have to multiply them, and the answer is 260. The nearest option is, of course, 200 to 250. So that would be the correct answer. Maybe they have taken 12 instead of 13, and then we get 240. Moving on to the next question. A 32-year-old pregnant woman at 32 weeks presents with pallor, fatigue, weakness. Okay, so we are thinking in terms of anemia. Peripheral smear shows hypersegmented neutrophils and macrocytes. Which of the following tests are useful to differentiate anemia of B12 deficiency from anemia of folic acid deficiency? Now, the difference between the B12 and the folic acid deficiency is that there will be normal methylmalonate. Now, let's read the option. There is an interesting pattern which I want you guys to notice and see in the questions. Decreased serum folate, increased methylmalonate, increased homocysteine. Now, these two options, one option says normal methylmalonate, another says increased methylmalonate. So you can easily rule out option 2 and option 4 because at a particular time, no two options can be correct simultaneously. So either it would be normal or it would be increased. So in B12 deficiency, there is increased in homocysteine, also increased in methylmalonate. Whereas in case of folic acid, there is only elevation of homocysteine and the methylmalonate level remains normal. So the answer over here is option 3. Moving on to the next question, which hormone is primarily responsible for the proliferation of the ducts in the breast during early pregnancy? So as we know, breast development, both estrogen and progesterone play a role. But estrogen is better option here because we are specifically asked about early pregnancy and proliferation of the ducts, whereas progesterone is majorly involved in creating the milk secretory alveoli. Which of the following is the strongest risk factor for developing gestational trophoblastic disease? Now let's read the option. Maternal age below 35, use of oral contraceptive pills. Now these are not the risk factors for GTN, so we can rule out these two options. In fact, OCP provides protection. ethnicity is a risk factor, but ethnicity is never considered one of the strongest risk factor, whereas previous history of a molar pregnancy is one of the strongest risk factor for developing gestational trophoblastic disease. So if there is one molar pregnancy before, it suggests a risk of 1 to 2%, whereas if there are more than one, like 2 or 3, the risk factor could also increase to 20 to 30%. So moving on to the next question, which glycoprotein is primarily localized in the chorion and decidua at the maternal fetal interface? So now this question has a very good like a clinical application and clinical correlation. So whenever we test for preterm labor, we always measure the fetal fibronectin level in the vagina to see if the patient is in preterm labor. And whenever it is more than 50, we come to a conclusion that the patient is in preterm labor. So here the answer is fibronectin. Moving on to the next question. A primary gravida, 42 weeks of gestation, comes to the ER with labor pain. She is at increased risk of all of the following complications except. So as we can see, she is postterm. Now, oligohydramnios, cord compression, and meconium stain lichen are all the complications of postterm pregnancy, whereas polyhydramnios is rarely occurring in the postterm. So basically, the amniotic fluid is increasing till about 34 to 36 weeks, and after that, it starts to rapidly decline. So basically, the graph of amniotic fluid during pregnancy would be slowly increases, and after 34 to 36 weeks, it starts to decline rapidly. Right? That term, there is only 200 ml of amniotic fluid, whereas at 34 to 36, it could be even 1 to 1.5 liters. Right? So this is the physiology of the amniotic fluid. So basically, a postterm pregnant female will have oligohydramnios. She will have cord compression because due to the lack of amniotic fluid, the baby will compress the umbilical cord and it will result into cord compression. And meconium stained lichen is also one of the most common complication of postterm labor. Also, in cord compression, we see the variable decelerations in the CTG. So that is also one of the high yield facts. Moving on to the next question. A 16-year-old boy presents with a rash over both his forearms as shown below. So basically, there were the rash in the flexor aspect, especially around the cubital fossa. He states that he has a relaxing, itchy rash since childhood. Family history is significant for asthma and allergic rhinitis in his father. So we are already thinking in terms of a disease in which there is atopy. Which of the following is not a part of the diagnostic criteria for this disease? So the disease in discussion is atopic dermatitis. The diagnostic criteria is the Hanifa and Raschka criteria. So basically, there is the personal history and family history, visible dermatitis, and intense pruritus. But the onset of age of 16 years is not forming a criteria for the diagnosis. Basically, atopic dermatitis can happen in 3 age groups. In the first age group, where the children are just like infants, it is usually seen on the extensor aspects. Then in little older children, like in toddlers and in teenagers, it is seen in the flexor aspects plus the cubital fossa, whereas in case of adult presentation, it is just seen in the flexor aspect. Now there is a very interesting mechanism behind the development of these lesions. So basically, what happens while the child is very small and while the child is has not started to walk and he is just like crawling on the floor or crawling on any hard surface, there is basically scrubbing of the extensor aspects on the floor or any hard surface. So that predisposes them to develop the lesions on the extensor surface. Whereas in case of adults, there will be maximum contact when we flex our arms and flex our body. So basically, atopic dermatitis is related to the mechanical lesions. And whenever there is rubbing of any part, so that on that part, the risk of the lesion increases. So basically, that is the reason why in younger child and in infants, it is more on the extensor aspects, whereas in case of older child and adults, it is more in the flexor aspects. Moving on to the next question. 74-year-old female presents with persistent dryness and itching on her shin for the past few weeks. Examination shows erythematous exfoliated patches. Which of the following structures is primarily responsible for the lipid secretion in maintaining the skin barriers? So here the answer would be lamellar bodies or lamellar granules. The reason is that keratohyalin granules, these are responsible. If these are absent, there is a protein which is deficient known as the filaggrin protein, and they are responsible for ichthyosis vulgaris. Whereas elatin granules, they are seen in the stratum lucidum, especially of the palms and soles. Option 4 is the Burbrek granules, which are seen in the Langerhans cell histiocytosis. So basically, they are tennis racket shaped granules, and there is a positivity of CD1A. Moving on to the question 31. Identify the skin lesion and the disease associated with the image below. So basically, the image was provided of seborrheic dermatitis, and even without the image, just looking at the option, we could see that seborrheic dermatitis is present with scales and not with fissures. In pityriasis versicolor, we don't see target lesions. Also in pityriasis rosea, there is a Christmas-tree distribution of the lesions. Which of the following are recommended during postpartum hemorrhage, blood loss management, except? So we are asked that what we want to do in case of postpartum hemorrhage. So maintaining the hemoglobin above 8 gram per dl, that makes sense. We want to do that. Keeping the platelet more than 50 into 10 raised to 9. So that also we want to do. APDT less than 1.5. That is also something we target. Routine use of recombinant activated factor 7. Now, in any exam, if you read the word such as all, none, or like routine use, most probably that is the wrong answer, because in medicine, there is nothing like we do this routinely, right? Always there are some indications for any procedure. So also, if you have done your internship, we do not like routinely use recombinant activated factor 7, but we are supposed to do these things, monitor these things in a patient of PPH. So option 4 is the correct answer. Moving on, which of the following is not a correct statement with respect to selective intrauterine growth restrictions? So we are asked about IUGR and there are some values. The fetal weight of one twin is less than 10th percentile. Okay, this seems correct. There's a difference of weight of more than 25 between the twins. Again, this seems correct. Both twins have unequal share of placental mass. Again, this seems correct. MCA Doppler is used as the main modality of diagnosis in IUGR. Now, this question, a lot of people might find it confusing. So what would have I done if I was at your place? So in option 4, it talks about MCA Doppler. Now we know that MCA Doppler is classically used for treating or for diagnosing fetal anemia, right? And umbilical artery Doppler is used in IUGR. Right. So MCA Doppler should not be used in diagnosis of IUGR. So with the existing knowledge, you are able to arrive at this answer, even though you are unaware of these three options. Also, can anyone name in the live chat that what is the grading? What is the name of the grading used for selective intrauterine growth restrictions in case of twins? So basically, we use the Quintaro staging for the IUGR, especially involving the twins. So moving on to the next question. Which type of maneuver is depicted in the image below? So the image showed breech delivery, and the image showed a maneuver of Burns-Marshall maneuver. It didn't involve any use of forceps or any of the other maneuvers. 28-year-old woman at 41 weeks of gestation is being considered for induction of labor. All of the following are contraindications to induction of labor except. So we are here asked the contraindications for induction of labor. So placenta previa, active genital herpes, and fetal distress are contraindications for the labor. In case of placenta previa, the placenta itself is covering the os, the internal os of the cervix. So there are no chances of happening of normal delivery. In case of active genital herpes, there is active infection in the genital region. So there will be very high chances of transmission of the herpes virus to the child. Whereas in case of fetal distress, we usually go for a emergency LSCS instead of a normal labor. So postpartum pregnancy is not a contraindication for induction of normal labor. Moving on to question 36, which of the following statements accurately describes a refractory period on a neuron signaling properties? Now, this is a very, very interesting question, and it requires like a really good hold over concepts of physiology. Now, let's understand. So basically, this is the neuron. Let's make it a bit wider so we can write inside it, right? So basically, this is a neuron. Now let's suppose that the neuron is negatively charged inside, right? It maintains a negative resting membrane potential throughout. Now, what happens? Now, basically, what we are asked is what is the nature's application for providing refractory period, right? What is the application of refractory period? Now, that is what we are asked. Now, let's suppose we have an action potential from this direction. It will depolarize the membrane, so it will cause positive charge inside and negative charge outside, right? So right now there are positive charge outside. Now, as soon as a signal comes to the neuron, what will happen is there will be difference, there will be change in the charges. So for one particular movement, what will happen is there will be positive charge inside, negative charge outside. So basically, this segment of the neuron will be undergoing depolarization. Now, the next segment of the neuron is still in the resting potential. So it could be depolarized. So in the next phase, when the charges will move, this whole depolarized segment will move on to the next part of the neuron. So what will happen in the next phase is that this part of the neuron will be positively charged and this part of the neuron will be negatively charged. So the impulse, the direction of impulse is in this direction, right? So we want the direction to move in the right direction. And again, here the charges will revert back to the original charges. So now the depolarizing segment is here, right? Now let's suppose that there was no refractory period. Now the problem would be this charge could again depolarize the retrospective segment and it could depolarize the anterograde in the retrograde direction simultaneously. So there will be no net flux of the current in the neuron. So in order to prevent this retrograde transmission, the body has created the refractory period, right? So even if it is a strong stimulus, the neuron cannot depolarize in the opposite direction, and it will only depolarize in the forward direction. So basically, this is the physiological reason behind creating the refractory period. This was a tricky question. This was a very good question. It could only be answered if you have a strong concepts in physiology. So basically, the answer would be it ensures the action potential moves in one direction along the axons. Moving on to the next question. 9-year-old boy, episodic pain in his extremities, skin findings shown in the image below, progressive renal dysfunction, biopsy of skin reveals accumulation of ceramide trihexycide, and alpha-galactosidase deficiency suspected. So basically, we are given what deficiency we are suspecting. So actually, there is no requirement of the image in this question. But still, the image that's shown had a lot of like telangiectasias shown. So basically, it is a Fabry's disease. And in Fabry's disease, we see alpha-galactosidase deficiency. In case of Tay-Sachs, we will see cherry red spots, but there would not be any hepatosplenomegaly. So none of those history is mentioned. In crabs, we will see accumulation of globoid bodies, and there would be beta galactosidase, not alpha. In Gauchers, again, there would be deficiency of glucocerebrosidase, and there would be a history of crumpled tissue paper appearance, fragile bones, causing Erlenmeyer flask deformity, right? So none of those is mentioned in the question. Moving on, a 45-year-old woman presents to the ER with severe right upper quadrant abdominal pain. So what we are asked are some conditions of the biliary system. Let's read the last line. Which anatomical landmark within the Calot's triangle would be most helpful in locating the cystic artery? So basically, we are asked about the content of the Calot's triangle. So all of this is usually fluff. It is not required. So it's always recommended to read the last line. And from the last line, you could manage to answer the question. In the Calot's triangle, we have two contents. One are the lymph nodes and other is the cystic artery. So we are asked what would be the most helpful in locating the cystic artery. So the cystic lymph nodes, which are located in the Calot's triangle, would be the most helpful to identify the artery. So it would be the option 2. Moving on, which of the following would possibly confirm the diagnosis of myasthenia gravis following the hydrophonium test? Now, this is also known as the tensilon test, in which you give a small amount of hydrophonium and check for the response. Now, temporary improvement in muscle strength after administration of hydrophonium. This is classical for myasthenia gravis, whereas worsening of muscle weakness after administration of hydrophonium. This is classical for cholinergic crisis. What basically happens is hydrophonium works in a similar way as physostigmine or neostigmine. So it will inhibit the acetylcholine esterase and will help in the buildup of acetylcholine in the synaptic cleft. Now this will result into improvement in the myasthenic symptoms. We can also use the ice pack test, in which we put ice pack onto the patient's eye, and we also look for the similar kind of response. Moving on to question 40, 65-year-old woman with schizophrenia treated with haloperidol develops worsening tremors and stiffness. She exhibits bradykinesia, rigidity, and resting tremors, suggestive of Parkinsonism. To manage these symptoms, she is prescribed an anticholinergic. Which of the following is not typically anticholinergic drug, but still used for this purpose? Now, from our general pharma knowledge, we know that benzoxazole, benztropine, and bipyridine, all of them are anticholinergic. Whereas promethazine is an antihistaminic containing anticholinergic properties. So the answer over here is option 4, promethazine. Right. Moving on to the next question. Match the following medications with their side effects. Now, the medications we are given are metoprolol. Let's highlight the both of the columns. Metoprolol, ivabradine, trimetazidine, enoxaparin, nicorandil. And we are given the side effects, contraindicated non-DHP, the risk of polar cells. So now, in such questions, which are tricky questions, we need to identify one or two of the options in which we are 100% sure. For example, in case of metoprolol, it is the abrupt stoppage of a beta blocker will result into exacerbation of angina. Now let's understand the physiological mechanism behind this effect. Now, whenever the patient is on beta blocker, there will be increase in the amount of beta receptors, everywhere in the body, as we are basically starving the beta receptors by blocking them. So whenever we will stop beta blocker, all the beta receptors, all the upregulated beta receptors will show reflex increase, and there would be an exacerbation of angina. This is the same mechanism for clonidine withdrawal. So we can see that in the column A, the option C matches. So we can again rule out two options from it. Next, what we know is enoxaparin. Now, enoxaparin, it is contraindicated in renal insufficiency. As we know that LMWH, which means low molecular weight heparin, are contraindicated in renal insufficiency, whereas unfractionated heparin are relatively safer in case of renal insufficiency. So again, in 4, we know that the option matching is E. So again, this option is out. So we arrive at the right answer. Now let's match the other options. Ivabradine is contraindicated in non-DHP calcium channel, contraindicated with non-DHP calcium channel blockers. Now, ivabradine itself causes bradycardia. Non-DHP calcium channel blockers, it will also result into bradycardia. Now, even like metoprolol could match with A, as it is also contraindicated with non-DHP calcium channel blockers. Then trimetazidine, it has increased risk of Parkinson disease, and nicorandil, it is notorious for causing increased risk of oral ulcers. Let's move to the next question. We asked what is the mechanism of drug A. Patient who had a history of myocardial infarction diagnosed with heart failure, which was prescribed drug A after monitoring renal function and potassium levels for a trial period of 4 weeks. So classically, whenever we are going to start an ACE inhibitor, we need to monitor the levels of potassium and renal function. Because as we know that ACE inhibitors have a side effect of causing hyperkalemia, which could be detrimental in case of heart failure patients. So we'll always monitor renal function test and potassium level in cases of starting the patient on ACE inhibitors. Moving to the next question. 28-year-old woman with a 12-day history of missed period and a positive pregnancy test undergoes a procedure to empty her uterus. Identify the instrument used in the early pregnancy for the management. So here the image was given of a menstrual regulation syringe. Now there is a very minute difference between the menstrual regulation syringe and a manual vacuum aspirator. So the menstrual regulation syringe will only have one valve, whereas the manual vacuum aspiration will have the valves on both the sides. Also, another difference is the menstrual regulation syringe we can use up till 6 weeks of pregnancy. Here we are given 12-day history, which means 4 weeks of the last month and plus 12 days. So she falls within the range of 6 weeks. So the answer and the option here was menstrual regulation syringe. Moving on to the next question. During the puerperium, the female reproductive tract undergoes involution, changes, and reverts to the non-pregnant state. All of the following statements accurately reflect these changes except. So let's read the option. Cervix thickens and endocervical canal reforms by the end of first week. Okay, that seems correct. Total number of myocytes decline. Okay. Complete involution of placenta takes up to 6 weeks. Again, this is correct. Rugae starts to reform by 2nd to 3rd week. Okay, this option I'm not sure about. So we are thinking in between the option 2 and option 4. Now, from my basic pathology and physiology knowledge, I do know that the myocyte will not decline, but it will just get atrophied, which means that the number will not reduce, but just the size will reduce. So the answer here would be option number 2. The total number of myocytes decline. So basically, after pregnancy, the myocytes will not decline, they will undergo atrophy. So there is not a decline in the number per se. But in cases of pregnancy, the myocytes will undergo hypertrophy as well as hyperplasia. So there will be increase in the number of myocytes as well as the increase in the size of the myocytes. Moving to the question 45. Effects of various agents on the membrane potential of intestinal smooth muscle is given below. Which of the following substance produces the response labeled B? So basically, there was a graph showing increased response and decreased response. If this is the baseline, we were asked that what will this graph, which drug will cause this graph, right? So basically, we are seeing that in cases of GIT, whenever any drug stimulates the cholinergic system, it will increase the secretion, it will increase the contractility. But any sympathomimetic drug will reduce the contractility and it will reduce the secretions, right? So here the option would be adrenaline. Stretch will cause increase, cold and acetylcholine will again cause increase in the contractions. Moving on to question 46, which of the following statement regarding facilitated diffusion is false? It does not require ATP, that is correct. Involved protein is stereospecific and follows saturation kinetics, again that is correct. Diffusion of ammonia in collecting ducts is a type of facilitated diffusion. No, this is the wrong statement, as ammonia is a gas and it follows simple diffusion. It does not require any specific protein for its diffusion. So here the answer will be option 4. Molecules move down the chemical gradient from high to low concentration. Again, this is the correct statement. Only in cases of active transport, the molecules will move against the concentration gradient. The next question, which is following is true regarding the structure of glycogen. Arranged in 12 concentric layer. Okay, this is I'm not sure about. Glucose residues are connected by alpha 1,4 linkage. This is true. Branch points are formed by alpha 1,6 linkage. Again, that is true. So 2 and 3 are correct. So we are left with 2 and 3 and 1, 2 and 3. So in these questions where you don't know the specific answer, it's always better that you eliminate at least 2 of the option and then take a educated guess. So if I would have been in the place, I would go for a question like the options 1, 2 and 3 are correct. But this is actually a random number, like you will have to remember this fact and move on. Moving on to question 48, which of the following statement regarding the aerobic glycolysis is true? Each acetylcholine molecule yields 5 ATP by converting to pyruvate. Okay. Each molecules of NADPH yields 2.5 ATP. Again, that is correct. Okay. So basically, this is a wrong statement. I forgot to read NADPH. Every molecule of NADH will convert into 2.5 ATP. Aerobic glycolysis of one molecule of glucose yields a total of 7 ATP. Yes, that is the correct statement. Each turn of citric acid cycle produces 20, not, it will produce 10 ATPs. And the acetyl-CoA will never convert it to pyruvate. So this was a trapper. Again, this is a wrong statement. So whenever you think 2 statements are correct, you need to find out which one makes the more obvious sense and which one is a trapper. So acetyl-CoA never can convert into pyruvate. It is only a one-way channel. So in this question, this would be wrong. This would be wrong because there is NADPH, and this would be wrong because there are 10 ATP production and not 20. So the correct answer is option 3. Moving on, analyze the structure of mucopolysaccharide shown below. Which mucopolysaccharide is represented in the image? So basically, there was a structure showing a galactose sugar. And as we know that the galactose sugar is only seen in keratin sulfate. Also, that the keratin sulfate is responsible for the transparency of the cornea and transparency of cornea. Heparin sulfate, it is used in the basement membrane of the kidney, and it is negatively charged and it repels the negatively charged protein from filtration. Whereas chondroitin is present in the cartilage and dermatan sulfate is present in the skin. Moving on to 50th question, which of the following are the correct regarding anaplerotic reaction? Now, anaplerotic reactions are the reactions which replenish the products in the tricyclic acid cycle, right, or the Krebs cycle. So basically, the answer would be replenish the TCA intermediates, right? There are certain set of reactions which are known as the cataplerotic reaction. They will reduce the number of intermediates in the body, whereas anaplerotic reaction, they will increase the number of these intermediates in the body. Intermediates such as succinylcholine, malate, right, which are used, oxaloacetate, which are used in formation of other important compounds in the body. So let's take a quick break for 2 minutes. If you are continuously seeing this, I would recommend you do some neck stretches, drink some water, and return back in 2 minutes. So we'll just take a small break of 2 minutes. Hello everyone, welcome back, and let's continue with the review. So starting with question number 51, which sequence correctly represents the steps of oxidative phase of pentose phosphate pathway? Now, the oxidative phase is the first half, and the energy producing or the non-oxidative phase is the second half. The non-oxidative phase are usually the reversible steps, whereas the oxidative phase is the non-reversible steps. So we'll start with glucose 6-phosphate, right? We will not start with 6-phosphoglucolactone. We will not start with 6-phosphogluconate. So we have eliminated two options. Then with the help of glucose 6-phosphate dehydrogenase, it will convert into 6-phosphogluconolactone. So option 3 is correct just by knowing the first two steps of the pentose phosphate pathway. So it's important that we don't need to know the entire pathway of biochemistries, but we just need to know a few of the important steps in the formation of these pathways. Right. So first glucose 6-phosphate to 6-phosphogluconolactone. Here we will generate one molecule of NADPH. And here the enzyme involved is 3,6-PD. Then it will convert into 6-phosphogluconate, and it will finally convert into ribulose 5-phosphate, again generating one molecule of NADPH. So the production of NADPH suggests that this is the oxidative pathway. Now the main sole purpose of this pathway is to generate two things, NADPH and ribose 5-phosphate. This would be utilized in the nucleic acid formation, and this would be utilized as a reducing equivalent in different processes of the body, such as fatty acid synthesis and fatty acid metabolism. Moving on to the question number 52. The image below shows the site of action of different ETC inhibitors. Based on the image, which of the following site of action of cyanide? So basically we don't have the image. So let me tell you that cyanide will inhibit the complex 4, and the inhibitors of complex 4 are repeatedly asked. You can easily remember that the complex 4 is inhibited by all the gaseous inhibitors such as cyanide, hydrogen sulfide, right? So basically these gaseous inhibitors will inhibit the complex 4, whereas oligomycin will inhibit the complex 5. Rotenone and other related drugs will inhibit the complex 1. Question 53. What chromosomal abnormality is most likely causing this disease? So we are asked about the chromosomal abnormality from the options. 30-year-old tall male patient to the clinic for fertility treatment. He has low sperm count, history of diabetes, physical exam shows gynecomastia, small testes, and minimal facial and body hair. So it is a textbook definition of Klinefelter syndrome, which is XXY. Option 2 is correct. So can anybody tell me that how many bar bodies will we see in the patient of Klinefelter's? So basically, bar bodies are the lionized form of X chromosomes which are inactivated. So basically, in Klinefelter syndrome, or in case of a normal female, we will see one bar body. So the concept of bar body is that if there are two X chromosomes, one will be lionized, so that will be visible as the bar body. So in normal female having XX, there will be one bar body. In Klinefelter XXY, we again have one bar body. But in normal males, we have zero bar body. In Turners, we again have zero bar bodies. Moving on to the next question, 65-year-old male presents with weakness on the right half of his body. He is known case of atrial fibrillation, not on any treatment. CT angio shows complete occlusion of a small branch of middle cerebral artery. Which of the following is likely change seen is pathology? So basically, this is a case of brain stroke, right? And in stroke, we know that in certain organs, there is liquefactive necrosis, such as in case of pancreas and in case of brain. So here, the answer would be liquefactive necrosis. Coagulative necrosis is classically seen in solid organs such as kidney and the liver. Apoptosis, it may be physiological or it may be pathological, but in brain stroke, there is no apoptosis. Fibrinoid necrosis is again seen in conditions such as such as malignant malignant hypertension and polyarteritis nodosa. So again, fibrinoid necrosis will not be the answer here. The correct answer would be option 2, liquefactive necrosis. Moving on to the next question. A patient presents with fluid accumulation, pleural cavity. Which of the following characteristics would be consistent with a diagnosis of exudative rather than a transudative? So high LDH points towards exudative, low protein points towards transudative, presence of mainly albumin again transudative, low specific gravity again transudative. So basically there is a light criteria which we use to differentiate between exudative and transudative. So in the light criteria, high LDH, high protein suggests effusion to be more in terms of exudative rather than a transudative one. The reasons for exudative effusion are any like malignancies or tuberculosis, and the reasons for transudative ones are like non-inflammatory conditions in which there is serous fluid in the pleural cavity. Moving on to the next question, 40-year-old female. So again, this is a long question. Let's read the last line first. What is the most likely diagnosis? Okay, we are dealing with salivary gland tumors. 40-year-old, slowly growing, painless mass. Left parotid, several months. On examination, firm and mobile, non-tender mass is palpated in the preauricular region. So most likely, we are dealing with a parotid tumor. Let's read further. Fine needle aspiration cytology reveals epithelial cells and myoepithelial cells in a chondromyxoid background. Now, first clue is that we are having a firm, mobile, non-tender mass. So firm mass will always point toward a benign pathology rather than a malignant one. So we can rule out the malignant ones. Again, Warthin's tumor is classically seen in males, but the patient is female, but we cannot rule out on the basis of gender. Again, the Warthin tumors will have bilateral presentation. Here we have just a unilateral presentation. Warthin's tumor will be associated with smoking. Here there is no history of smoking given. And the main thing on which we are ruling out Warthin's tumor is that the biopsy or the FNAC. In Warthin's tumor, we will see two layers of the cell, whereas pleomorphic, as the name suggests, it has a lot of morphological features on FNAC. So it has epithelial cells, myoepithelial cells in a chondromyxoid background. Also, the most common tumor in parotid is pleomorphic adenoma. So here the questions here the question was filled up with a lots of hints, right? Moving on to the next question. Again, a match the following type. Let's highlight hyaline cast, muddy granular cast, waxy cast, and fatty cast. Nephrotic, CRF, ATN, fever. So as we know that the hyaline cast are the physiological cast, it could be raised in cases of fever, dehydration, pregnancy. So we know that in one, the matching option would be D. So we could rule out two options. Next, we will see about the nephrotic syndrome. And in nephrotic syndrome, we will see. Okay, so in the muddy granular cast, we will see in acute tubular necrosis, whereas in nephrotic, we will see waxy cast. Just a second. Hyaline cast are seen in fever, so we have ruled out two options. Second, for the muddy granular cast, we are to select between option A and C, either nephrotic syndrome or acute tubular necrosis. Yes. So in 2, it would be C. In 3, waxy cast, it would be chronic renal failure, and in fatty cast, it would be nephrotic syndrome. Because in case of nephrotic syndrome, we see lipiduria, which is lipid present in the urine. So fatty cast is classically seen in nephrotic syndrome. So here the option would be option 3. Next, moving on to the 58th question. 35-year-old woman comes to the clinic presenting with swelling in the upper quadrant of her left breast, reports change in the skin and surrounding nipple area complex as well. All of the following is the risk factor of this condition except. So here we are dealing with breast CA. The risk factors of breast CA we are asked. So early menarche, it means higher estrogen exposure. So it is a risk factor. Age is a risk factor. Alcohol and smoking are again a risk factor. But multiparity is a protective factor. As in multiparity, there is less cumulative exposure of estrogen. The reason being that each time a woman becomes pregnant, there is a reduced level of estrogen and high level of progesterone. So basically, it protects the breast from continuous estrogen exposure. So multiparity is the right option here. Next question, which of the following is the most likely diagnosis? So here the image showed pleomorphic nucleus. Now pleomorphic nucleus will rule out any benign pathology. Also, the cells had fat filled up into them. So leiomyosarcoma will have lipid fat, like lipid cells, fat cells, and muscle cells, myocytes. The image did not show any myocyte. Again, rhabdomyosarcoma, it will have classical spider cell. But again, the image did not show any spider cell. So the right answer would be liposarcoma. Right, moving on to the next question. 65-year-old male presents to the hospital with a painless scrotal mass. Ultrasound scan shows solid testicular mass suspicious for a spermatocytic tumor. Upon further examination, the following histological features are identified except. So again, this kind of tumor is new for me. I haven't heard spermatocytic tumor. So let's see how we will approach this question. Associated with gain of function mutation, okay, it could be presence of inflammatory infiltrates in the syncytial trophoblast. So this basically looks more in terms of GTN, gestational trophoblastic neoplasm. But let's read the other options. Presence of 3 intermixed types of cell, okay, and lower risk of METs following surgical resection. So I have no idea about option 1, 3, and 4, but I'm definitely sure that syncytial trophoblast are not associated with this, and they are more associated with tumors involving the syncytium. So this would be the correct answer, as there are no syncytial trophoblast in a male patient, and we are clearly given that the patient is male and having a testicular mass. So by this elimination method, you could rule out the options and come to the right answer. Next, we are asked about which of the following describe the location of the split in the Bullous disorder. 55-year widespread blistering disorder in the skin and oral mucosa. So in bullous pemphigoid, there is no involvement of the oral mucosa, whereas in pemphigus vulgaris, we have the development of skin and oral mucosa. And in case of pemphigus foliaceus, skin biopsy reveals acantholysis and intraepidermal blisters formation above the basal layer. So again, above the basal layer, which in itself has given the answer that the answer would be suprabasal split, and we will see a row of tombstones appearance. And on direct immunofluorescence, we will see a fishnet pattern in case of pemphigus vulgaris. The next question, 14-year-old adolescent presents with recurrent episodes of unexplained swelling and pain following minor injuries and physical activity. Upon examination, signs of localized swelling and tenderness. Lab investigation revealed normal platelet and bleeding time, but clotting time was prolonged. Which of the following would strongly suggest a coagulation defect? So here we are given that the platelets were normal and the bleeding time was also normal. So the problem is not with platelet. The problem is with the coagulation factors. And out of the given options, hemarthrosis has the defect in coagulation factor, which is also seen in the patients of hemophilia. Also, if I would have not known about this at all, I could easily see that petechiae, purpura, and ecchymosis are all related to the problem in platelets, whereas hemarthrosis is the odd one out. And usually, if you can find out the odd one out in the options, most probably that is the answer. So hemarthrosis would be the answer of the question. Moving on, 28-year-old woman has multiple episodes of feeling euphoric, highly energetic, needing little sleep lasting for 3 to 4 days. So we are thinking that it could be either mania or hypomania. However, her symptoms never impair her work or social functioning. So this is a strong pointer that we are talking about hypomania and not mania. Because in mania, the work impairment would be present. She also had episodes of prolonged low mood and anhedonia lasting several weeks. Which of the following is the most likely diagnosis? So we are also seeing depression plus hypomania, making it a classical bipolar 2. In bipolar 1, there would be episode of mania. So one manic episode is important to make a diagnosis of bipolar 1. In cyclothymic disorder, we will not have such exaggeration of euphoria, highly energetic behavior, and little sleep. This is clearly indicating hypomania. And in major depressive disorder, we will not have these positive symptoms. Moving on to the next question, we are asked about neurosis and psychosis. Insight and judgment are intact in case of neurosis, and intact realities and testing is seen in psychosis. Now, this is the wrong statement, as in psychosis, the touch with reality is usually impaired. Also, the judgment and the insight are impaired. Psychosis, the example could be schizophrenia, whereas neurosis, there would be several examples such as OCD, phobia, etc. So statement 1 is true, statement 2 is false. The right option would be option 1. The next question, 28-year-old G3P2 woman, 39 weeks, history of previous years, with spontaneous labor in the labor ward, just delivered a healthy baby girl via vaginal delivery. She has been diagnosed with severe anemia. Obstetric team is concerned about the risk of PPH. What is the next best step in our management to prevent PPH? Maintaining hemoglobin more than 10, okay, but it will not prevent the ongoing PPH. Administer oxytocin 25 international units. Now, this is a very high dose of oxytocin. We usually go for 5 to 10. Localizing the placenta using USG or MRI. So there are no signs of retained placental tissue. Administer oxytocin infusion for at least 1 hour after delivery. That seems to be a correct option. So I hope you are understanding how I'm ruling out the other options and arriving to the right answer. 33 weeks of gestation, umbilical artery Doppler imaging shows the following finding. So this was basically the following finding. This is the baseline. So this was the following finding. As you can see, the blood flow is getting reversed in this direction. This is the baseline. So this is 0. And the blood flow is getting reversed. Right. So in case of reversed end diastolic flow, we usually go for immediate termination of pregnancy. We will not wait for 34 weeks. This we can do if there is absent end diastolic flow. will not continue this pregnancy to term. Reverse end-diastolic flow is an immediate indication to terminate the pregnancy. Also, severe impending preeclampsia, eclampsia, and HELP. These are some of the factors in which we go for immediate termination of pregnancy. Moving on to the next question. 45-year-old male, pre-op evaluation. During the airway assessment, the base of the uvula is visible with the soft palate and the hard palate. Based on the finding, which Mallampati classification is the most appropriate for this patient? So if we are said that the entire uvula is visible, then it would be a Mallampati class 1. If we say that the tip is obscured, then it would be 2. If we are told that the entire uvula is obscured, just the base is visible, it would be 3. But if the entire uvula and the soft palate are not visible, only the hard palate is visible, it would be class 4. So basically, from the given history, it seems to be class 3. All among the following are true about adding adrenaline with lignocaine, except. So we are asked about the wrong statement. Increase in the duration of action. Okay, that seems to be correct. Decrease blood loss. Again, that seems to be correct. Contraindicated in patients of cardiovascular disease. That again seems to be correct. Increases the rate of systematic absorption. Now, the problem with lignocaine is that if we give lignocaine without adrenaline, the maximum dose which we can give is 5 mg per kg. And if we give it with adrenaline, the maximum dose increases to 7 mg per kg. So what adrenaline does is it vasoconstricts. So it increases the duration of time. It decreases the blood loss. It is contraindicated in patients with CVD because it causes vasoconstriction. But it reduces the rate of systemic absorption. That's why there is reduced chances of last. What is last? Last is local anesthetic systemic toxicity, right? And what is the preferred antidote if last occurs? The antidote is 20% interval. So option 4 would be the correct answer. Moving on to question 69. A 4-year-old child is brought to the emergency department in respiratory distress. What is the appropriate size of the endotracheal tube used to intubate the child? So in case of children, the calculation is 4 plus the age of the child divided by 4. So here what we have provided is the age of the child is 4 years. So the calculation is pretty simple. We get 5. The 5 mm is the appropriate size of the ET tube which is used in this child. Moving on to question 70. 65-year-old male with history of aortic stenosis, hypertension, recent cerebral venous thrombosis is on an anticoagulant therapy scheduled for a lower limb surgery. The anesthesiology team is evaluating the use of spinal anesthesia. Which of the following is not a contraindication for spinal anesthesia in this patient? Okay, so aortic stenosis. Now, in cases of aortic stenosis or coarctation of aorta or Eisenmenger syndrome, they represent fixed cardiac output. So when there is hypotension or when the cardiac output falls, the heart cannot compensate by increasing the cardiac output. So conditions having fixed cardiac output are usually the contraindication, including aortic stenosis, then coarctation of aorta, and Eisenmenger syndrome. Cerebral venous thrombosis is again a contraindication for doing spinal anesthesia. Vertebral osteomyelitis could again push the infection into the spinal cord. So again, it is a contraindication. But hypertension is not a contraindication of spinal anesthesia. In fact, hypertension will improve if we use spinal anesthesia as the blood pressure will fall due to the venous pooling in the lower limbs. The hypertension would be the correct answer here. Moving on to the next question, 60-year-old man with hypertension, coronary artery disease is undergoing general anesthesia for abdominal surgery. The anesthesiologist chooses to use isoflurane for maintenance of anesthesia. Which of the following is correct about isoflurane's effects and properties? Causes significant myocardial depression, okay? Increases the systematic vascular resistance, okay? Highly metabolized by the liver, okay? Provides cardioprotection through ischemic preconditioning. Now, as a fact, I'm not aware about the effects of isoflurane that thoroughly, but let's use some logic and common sense. Now, if the patient already has hypertension and coronary artery disease, the anesthesiologist would not use isoflurane if it would have been causing significant myocardial depression. So this is out. Also, if it increases the systematic vascular resistance, again, it will exacerbate the hypertension. So again, it should not be used. Now I'm confused between option C and option D. But option D seems more promising. The reason being it provides cardioprotection through ischemic preconditioning. Now what it means is that in cases of ischemia, if the heart will stop beating after 5 minutes, under the influence of isoflurane, the heart will continue beating for 7 to 8 minutes. It provides cardioprotection through ischemic preconditioning. So here option 4 would be the right answer. So basically it trains the heart to undergo stressful situation, especially in ischemia. So it is preconditioning the heart. As we are preconditioning ourselves by giving these GTs, the isoflurane will again precondition the heart to go through the ischemic phase. What is the type of torture method mentioned in the image given below? So basically the image showed wet submarine. So that would be the answer. It was a pretty easy image. Question 73. We are asked about the BNS appropriate. 32-year-old man gets into argument and intentionally causes severe injuries to another person, resulting into a broken arm and severe physical pain. So this qualifies to be grievous hurt. The police decided to charge him under the appropriate section of BNS. So basically 115, it is used for intentional simple hurt, whereas 117, it is used for intentional grievous hurt. Again, this is one of those facts which you need to revise like 1 week or 3 to 4 days before the exam. So BNS criteria, milestones, everything, you should have a different PDF in which you revise all of them just before the exam. Whereas BNS 124, it is for vitriolage or acid attack. Moving on to the next question. Which of the following is the most likely cause of his condition? And we are given some intracranial bleeds, right? Hemorrhagic bleeds. 65-year history of hypertension, presents in the ED with sudden onset of weakness of his right arm. He also complains of severe headache and nausea. On examination, his decreased level of consciousness, right-sided hemiparesis. A CT scan shows hyperdense lesion in the left basal ganglia. So what we see in epidural hematoma is a biconvex shaped lesion which involves the dura mater. So in this question, it cannot be the answer. In subarachnoid hemorrhage, we are usually given the history of like an older individual developing severe headache. So till here, it could have been subarachnoid hemorrhage. But in subarachnoid hemorrhage, classically, it would be mentioned the thunderclap headache. And in the CT, we would be seeing a star of death, which is hyperintensity in the CSF containing compartments, such as the cisterns, right? Subdural hematoma, again, it presents as a banana-shaped lesion on the CT scan. Here, there is no mention of that, although the age is resembling the one which we see in subdural hematoma. The answer which fits here is the hypertensive intracerebral hemorrhage, as there is hyperdense lesion in the left basal ganglia. So basically, it is a hemorrhagic stroke. Question 75, it's an assertion reason type of question. Appearance of stab wound is significantly influenced by the orientation of Langer's line in the skin. That is very correct. Stab wounds that are parallel to the Langer's line tend to be narrow and slit shaped, while those cut across the lines may gape due to skin elasticity and tension created along this line. This is also correct, and it is the reason for the assertion. So basically, Langer's lines are the tension lines which we find on our body. For example, these are the sets of Langer's lines. Now, the tension is applied in this direction, which is parallel to that of the Langer's line. Now, if any wound is parallel to the Langer's line, it will not gape. Instead, it will become a narrow slit-shaped wound. But if a wound is perpendicular to the Langer's line, it will be stretched because of the skin elasticity and it will gape. So you may have noticed that the surgeon always puts a horizontal incision on the abdomen. If we talk about a Pfannenstiel incision, it is also put horizontally. So the reason for putting horizontal incision is that it will provide better cosmesis and less amount of scar formation, as the Langer's line on the abdomen are horizontal. So here the option A would be the right answer. A ECG monitor should be attached while using a manual defibrillator. So option 2 is the correct answer. Moving on to question 77. A 40-year-old male was shot during robbery while walking home at night. The weapon used was identified to be a firearm, and the forensic investigators recovered a bullet from the scene as shown in the image below. So again, the image of the bullet, it showed a dum-dum bullet in which there would be the distal end of the bullet would deform itself in order to cause less trauma. Incendiary bullet would convert into a fire when striking the target. Souvenir bullet is one of the bullet which gets stuck into the body and it is not recovered from the body. The main problem with souvenir bullet is lead poisoning, as some bullets might contain particles of lead which slowly would leach into the body. It might cause lead poisoning. Moving on to question 78. During autopsy performed on body 20 years after the death, the pathologist notices a small blister filled with gas on the lower abdomen and the thighs. Which of the following is the likely cause of the blisters? Now, in case of burn injury, especially the antemortem burn, there would be blisters, but it would not be gas-filled blisters. It would be filled with the inflammatory fluid. So it's a wrong answer. Again, friction blisters and chemical exposures will not have typical gas-filled blisters on the lower abdomen and the thigh. So this gas-filled blisters is a hallmark of decomposition due to gas formation. A 38-year-old male patient presents with chronic pain and intermittent purulent discharge from a sinus over his right tibia. Months ago, an X-ray shows the following finding. Which of the following is likely responsible for this? So this question seems to be of chronic osteomyelitis. In chronic osteomyelitis, sequestrum formation is classically seen. In the image, there was a dense bone which was looking like a sequestrum. So the answer would be sequestrum formation. Moving on to question number 80. 25-year-old male had pain and progressive swelling around the proximal part of the left hand in the last 3 months. The X-ray shows is below. The X-ray shown below. A biopsy reveals small round cell tumor forming pseudo-rosettes. Which of the following is not correct regarding the diagnosis of this patient? So basically what the X-ray showed was onion skin appearance in the proximal part of the left hand. And along with that, small round cell tumor forming pseudo-rosettes. These are the classical buzzwords to diagnose the patient as Ewing's sarcoma. And in case of Ewing's sarcoma, we see a translocation of 1122 and CD99 positivity. There is a defect in the gene EWS. So let's read the option. Highly malignant tumor of the bone commonly involving diaphysis. Okay, this seems correct. What we are asked are not correct. Bone-to-bone metastasis is not common. So this is a wrong statement. In fact, Ewing sarcoma is one of the most common bone tumor to metastasize to another bone. Tumor is highly radiosensitive but prone to recurrence. This is again true statement. Males are more likely to be affected than female. Again, this is a true statement. So option 1, 3 and 4 are true. Option 2 is the false one here. Moving on to question 81. Which imaging modality is considered best for assessing the vertebral body destruction and sequestrum formation in the port spine? Now, whenever we are told to choose between CT scan and X-ray, we'll choose CT scan as it is always having better resolution than X-ray. Now, why not MRI and why not ultrasound? Now, ultrasound we can rule out as ultrasound is best for fluid-filled lesions, right? So ultrasound is not useful in vertebral bony destructions. Why not MRI? Now, MRI is classically used for imaging soft tissues like nerves, tendons, sheaths, etc. Also, we use MRI in orthopedics, but majorly to see bone edema and not to see the bone destruction. So in bone destruction, the best would be CT scan. Moving to the next question, question number 82. 28-year-old male athlete presents with severe pain and swelling on of his right shoulder after falling during a basketball game. The physician suspects acromioclavicular joint injury and orders an X-ray. Now, these views are again factual. If you don't know them, it's better to give such questions rather than attempting them. If you are able to rule out some of the options, it is better that you should attempt it. But there will be like 10 to 15 to even like 20 questions in the actual exam, which are not meant to be answered, which are the trappers. And if you attempt them, it would be like, it would do more harm than good. Then it's like recommended to leave such questions. However, the cephalic tilt, it is used to see the clavicle. The west point, it is used to see the anterior humerus. So lesions such as the Benkart lesion are visualized on the west point view. Serendipity view, it is used for the sternoclavicular joint. In Zanka view, it is for the acromioclavicular joint. We are asked about the acromioclavicular joint, so option 4 would be the correct answer. Label the contents of middle ear appropriately. Again, so there was an image given and we had to like just label the bones, and it was a quite easy image. You could have easily like solved it. Just one thing, that stapedius always goes with stapes. So from that, we could eliminate the rest of the 3 options and could arrive at the right answer. Question 84, 55-year-old woman experiences brief vertigo when turning into the bed. A test is performed as shown below. And horizontal nystagmus is observed. Which of the following test was performed? Now let me try to recreate the image. So basically, this is the body of the patient. And the head of the patient was elevated to about 15 to 30 degrees. And the head was turned to both the sides, one after the another. So my first question would be, which of the semicircular canals are we testing here? So whenever we elevate the head and we rotate the head, we are checking the lateral semicircular canals. Whereas in case of Dick Solpike, we usually let the head hang backwards to check for the posterior semicircular canals. In the image, it was clearly shown that the head was flexed rather than extended. So flexion of the head would result into testing the lateral semicircular canal. And for that, we will use the supine roll test. Dick Solpike is for the diagnosis of BPPV, in which we extend the head. Apley's maneuver is for the treatment, which is more of an extensive maneuver, which involves the rolling of the patient. Also, we will ask the patient to sit up after we are done with the maneuver. Head impulse test is usually for nystagmus. Next, question 85. 5-year-old child, acoustic reflex testing, suspected hearing loss. Results indicate absence of a stapedial reflex at elevated sounds. Which of the following is most likely interpretation? Now, when will the acoustic reflex be absent? So either there is a problem with the stapedius muscle. So the stapedius muscle is provided, the innervation is provided by the seventh nerve. So either there is a problem in the seventh nerve or there is the problem in the input, that the sound is not reaching the brain. So that is the more likely cause here, the 5-year-old child. So we are more thinking in terms of conductive hearing loss. Normal hearing with no middle ear pathology, it is not possible. Mild sensory neural, it will not lead to stapedial reflex loss. Lesion in the auditory cortex, again, it will not lead to the absence of the stapedial reflex. So conductive hearing loss, also it goes well with the age of the child. Younger kids often have adenoid hypertrophy, and it can cause serous otitis media, resulting into conductive hearing loss, resulting into absence stapedial reflex. Question 86, 45-year-old patient, severe headache and fever. Patient has a history of chronic otitis media. CT is shown below. Which of the following statement best describes the most common complication of this patient? Localized pus collection within the brain parenchyma, inflammation of the meninges, pus accumulation between the skull and the dura, and blood clot formation in the sigmoid sinus. So basically, the CT scan showed a brain abscess, which is secondary to chronic otitis media. So the brain abscess we would define as localized pus collection within the brain parenchyma. Inflammation of meninges would present with Kernicson and Brudzinski sign. Pus accumulation between skull and dura are not seen in CSOM. Blood clot in the sigmoid sinus again points more towards sigmoid sinus or a hypercoagulable state rather than CSOM. The CT scan classically showed a fluid-filled hypodense lesion, which is more suggestive of the brain abscess. Question 87, 23 bivalents are formed in which stage of prophase 1? There are basically 5 stages. Leptotene, zygotene, pachytene, diplotene, and diakinesis. So basically in the zygotene phase, we see the formation of bivalent form. In pachytene phase, we see the crossover happen. In diplotene and diakinesis, the crossover usually separates out. In leptotene, just the chromosome becomes condensed. So the correct answer would be option 2, zygotene. Which of the following layer of skin with the cells present in it? Stratum corneum, stratum granulosum, stratum spinosum, and stratum basal. Melanocytes, keratins, keratohyalin granules, Langerhans cells. Now first, let's match what we already know. So we know that melanocytes are present in the stratum basal. So 4 would be A. So we are able to rule out 2 options. Now in stratum corneum, we are aware that there will be keratin tissue or keratin squamous. So 1 is B. So again, this one is ruled out. We are already with our answer. Let's check the other options. Stratum granulosum. The name itself is saying granulosum, so it might contain some granules, and the granules are of keratin hyaline. I had told you in the earlier question that keratin hyaline granules contain filaggrin protein, and if absent, it causes ichthyosis vulgaris. And in the remaining stratum spinosum, we have the Langerhans cell, which are the antigen presenting cells of the skin. Moving on to the question 89, stillborn baby was noted to have the following findings. The above pathologies derived from which of the following structures shown in the image below? So as far as I remember, the image showed the baby having the peeling up of the superficial epithelial layer, and the most resemblance was with okay, so that is a different question. In this question, we had a diagram of a baby showing the teratoma, and which was a oropharyngeal teratoma. and there were different parts mentioned in the diagram. If you have the diagram, kindly check it for the reference. There would be a defect in the primordial germ cell migration. So basically what happens is the primordial germ cell has to migrate towards the primitive streak to form the gonads, sorry, to the gonadal area to form the gonads. But if it migrates towards the mouth, it forms the teratoma, which is known as oropharyngeal teratoma. Okay, a 35-year-old patient with chronic hepatitis C undergoes a liver biopsy. The pathologist observes a classical hexagonal structure of the liver lobule. Which of the following statement is correct regarding the blood flow and the architecture within the liver lobule? Blood flows from the central vein to the portal triad. So basically, this should be the opposite. The blood flows from the portal triad to the central vein. So this is incorrect. We are asked about the correct option. The hepatic artery provides 70% of the liver's blood supply. Now, this is again incorrect, as majority of the blood supply is by the portal vein. Bile flows in the same direction as the blood within the lobule. Again, this is a incorrect statement. Sinusoids drain blood into the central vein. This is the correct statement. Actually, bile flows in the opposite direction towards the bile ducts, while blood flows towards the central vein. If here is the central vein and here is the portal triad, bile will flow towards the bile duct to get excreted, whereas from the portal vein, the blood from the portal vein and the hepatic artery will flow towards the central vein. So here the option 4 will be the correct answer. The stomatodium is derived from which of the following layers? So again, this is a factual question. The stomatodium is derived from the ectoderm. Now, if I wouldn't have known the answer to this question, what I would have done is stomatodium sounds like stoma, which means mouth. Now, mouth cannot be derived from neural crest cells, neither it could be derived from the mesoderm. If you recall the embryology of the opening, the oral opening and the anal opening, we know that the opening, this is the mesoderm, and the ectoderm and the endoderm come and fuse together to form the opening. So the oral opening and the anal openings form in a similar way. So it's always either ectoderm or endoderm. So over here, the answer is ectoderm. Let's go to the question 92. 62-year-old woman with a history of tertiary hyperparathyroidism undergoes total parathyroidectomy. 3 days later, she presents with carpopedal spasm and numbness suggestive of hypocalcemia around her mouth. Her serum calcium is 6.9, so we are given the normal value of calcium is around 9 to 11. So the patient is clearly deficient in calcium. Which of the following is the likely diagnosis? Now the patient was a patient of hyperparathyroidism. So there would have been high parathyroid gland. And now we have removed the parathyroid gland, so there would be reduced parathyroid hormone. So basically, this is a case of hungry bone syndrome, in which during the high parathyroid, we are asking from the bone to give us the calcium to the blood. Now, the bone are losing its calcium to the blood under the influence of high parathyroid. Now, as soon as we remove the parathyroid gland, the level of parathyroid hormone will drop, and it will motivate the bone to again take up the calcium which has given into the blood back to it, resulting into hypocalcemia. So this is a hungry bone syndrome. Question 93, which of the following conditions are these CECT findings seen? So basically the CECT finding showed a central stellate scar. And as we know, central stellate scar is classically seen with FNH, serous cisadenoma of pancreas, and renal oncocytoma. So basically the concept behind this is that if any organ has center arteriole and it has smaller arterioles going from in to out, it causes a central stellate scar. So basically all of the above would be the correct choice. Let's go to the question 94. 40-year-old patient experiences persistent abdominal pain, elevated serum amylase after going ERCP. So mostly we are thinking in terms of iatrogenic pancreatitis.
The pain began shortly after the procedure. Which of the following is the most likely cause of patient's symptoms? So it is post-ERCP pancreatitis. In duodenal perforation, amylase might be elevated, but following ERCP, the most common complication is pancreatitis. Post-ERCP cholangitis will not have amylase raised. It would be more localized towards the right upper quadrant. Post-ERCP sphincter stenosis also is very uncommon. The post-ERCP pancreatitis fits the clinical scenario we are given. Question number 95, 27-year-old female presents with symptoms of weight loss, palpitation, and eye protrusion. We are thinking in terms of hyperthyroid condition, maybe Graves. Lab test reveals reduced TSH and increased T3, T4. What is the most likely diagnosis and primary target of this condition? So yes, low TSH, high T3, T4 suggest it's Graves' disease, and TSH receptor. We have long-acting stimulating receptors, last receptors which are elevated, which causes the hyperthyroidism. Question 96, which diagnostic finding is most indicative of insulinoma? So any tumor will produce the substance even when the substance is not required, right? So elevated serum glucose, it goes against insulinoma, as we know that insulin reduces the blood glucose levels. So this cannot be the option. Low C-peptide again cannot be the option because this insulin is endogenously produced. And in any endogenously produced insulin, it will also be secreted along with C-peptide. So again, this cannot be the answer. Elevated serum insulin during hypoglycemia. This seems to be correct, as in normal condition, in hypoglycemia, we will have low amount of insulin, and when we will have a diet rich in carbohydrates, the insulin level will increase. But elevated insulin during hypoglycemia suggests that it is a insulin. Hyperinsulinic response to oral glucose, again, this is physiological. So this will not be the answer. Question 97. Boundaries of Beer's triangle XL. So ITA, common carotid, and RLN forms the boundaries of the Beer's triangle, whereas superior thyroid artery does not form. Again, this is a factual question. It would be better if you could see the diagram of a Beer's triangle right now and consolidate this concept in your brain. Basically, Beer's triangle is used to localize the recurrent laryngeal nerve. Question 98, again a long-term question. What is the most likely diagnosis? So we are asked our diagnosis, and the option C that we are in the gallbladder. 58-year-old man, history of cholesterol stones, okay. Intermittent right upper quadrant pain, occasional nausea, USG reveals gallbladder mucosa and coarse granular appearance with small nodules, some larger polypoidal formation. Performing the lab chole of this patient following appearance constant was observed. So the image showed polysterosis, which is also known as a strawberry gallbladder. There would be these small appearances, granules embedded in the gallbladder wall. The answer over here would be polysterosis. Also, on the USG appearance, we will see a comet tail sign in polysterosis. Moving on to question 99. 45-year-old woman present with fatigue, difficulty swallowing, and pale skin. Investigation reveals a cervical esophageal web. So this is a classical presentation of Plummer-Vinson syndrome, which is a triad of iron deficiency anemia, glossitis, and esophageal web. The Plummer-Vinson would be the right answer. In Barrett's esophagus, we will not see iron deficiency, will not see pale skin, difficulty in swallowing. In achalasia, there would be difficulty in swallowing, but there would not be a cervical web. Again, in esophageal carcinoma, there would not be cervical web. However, Plummer-Vinson can predispose the patient to esophageal carcinoma, specifically the squamous variety. Question 100. 1-year-old child presents with macrocephaly, developmental delay, a significant reduction in motor skills, poor muscle tone, low IQ. At birth, the child was normal. Fundoscopy reveals the following. So basically, the fundoscopy reveals the cherry red spot. Along with that, we are seeing low IQ, developmental delay, and we are asked which is the most likely diagnosis. So in case of cherry red spots, we see Tay-Sachs and Niemann-Pick. Niemann-Pick is not in the option. So in Tay-Sachs, there would be no hepatosplenomegaly, but in Niemann-Pick, there would be hepatosplenomegaly. Rett syndrome would show the the child will first show normal developmental milestones, but then it will regress. It shows regression of developmental milestones. It starts after 2 years. Also, it is more common in females. Congenital brain malformation, it would be present since birth, whereas there is no history of hydrocephalus given to us. Let's take again a quick break of 2 minutes, drink some water, do some stretching. We are already halfway through, and we will continue the session in just 2 minutes. Okay, so let's start with question 101. By which age the milestone given in the image below is achieved by the child? So the image showed head elevation or head holding. Now head holding is usually attained by the child by the age of 3 months. So option 3 would be the correct answer. Moving on to question 102. 6-year-old baby was shifted to emergency, brought with severe respiratory distress. Patient X-ray is given below. Which of the following clinical investigation should not be done in this patient? So the X-ray clearly showed the intestinal loops coming into the thorax. So it was a case of CDH, congenital diaphragmatic hernia, and in such a condition, bag and mask ventilation is contraindicated. Now, the reason is whenever you give bag and mask ventilation, the air not only goes into the respiratory system, but it also enters into the intestine through the mouth and the esophagus. So it will further cause more inflation of the intestine, and it will further lead to compression of the lungs in the thorax. So bag and mask ventilation is contraindicated. It is also contraindicated in tracheoesophageal fistula. So it is contraindicated in two conditions, tracheoesophageal fistula and congenital diaphragmatic hernia. Question 103. We are asked the primary purpose of the maneuver. radial artery cannulation, 7-year child, continuous blood pressure monitoring during major surgery. Anesthesiologist compresses both the radial and the ulnar artery and asks the child to make a fist. Then releases the ulnar artery while keeping the radial artery compressed. So the name of the maneuver, which is done by the anesthesiologist here, it is the Allen's test. And correctly said, it is to evaluate for the collateral circulation in the hand. A genetic counselor is analyzing a family pedigree for a rare condition. The pedigree shown in the pedigree shows the following characteristics. Which of the following best describes the most likely mode of inheritance of this condition? Now the pedigree here showed the carrier state of female, whereas the males were affected. This pattern of pedigree is classically seen in X-linked recessive traits like hemophilia. So the answer over here is option 3. Moving on to question 105. 4-year-old boy presents with recurrent epistaxis, abdominal distension, splenomegaly. Laboratory investigation revealed anemia, thrombocytopenia, and reduced glucocerebrosidase. Which of the following is the most likely diagnosis? So in the earlier question, we had seen that glucocerebrosidase deficiency is seen in Gaucher's disease. So here the answer would be Gaucher's. Fabry's is alpha galactosidase. Krabs is beta galactosidase. So Gaucher's would be the answer, and in Gaucher's we can see crumpled tissue paper appearance.
Question 106. Brought to the pediatric clinic with 3-day history of high fever. On 4th day, the fever abruptly subsides as the child develops a rash as given in image below. Oral examination revealed ulcers and small red papules at the uvulopalatoglossal junction. What are these called? So first of all, it is important to diagnose the condition. It is a roseola, and in roseola, it is also known as the 4-day fever, in which the patient presents with high-grade fever for 4 days, and followed by there is abrupt reduction in fever, and then the rash appears. So this is the classical history given in roseola. In roseola, we can see Nagayama spots. Oblique spots are seen in measles. Cafeolar macules are seen in neurofibromatosis and also Macular-Albright syndrome. Question 107. 8-month-old baby is brought to the hospital after a mother noticed rash all over the baby's body. The mother gives a history of syphilis during the pregnancy. Which of the following is not an early sign of syphilis? Now, even if you don't know this question, you could just apply logic to rule out the options. Mucocutaneous rash, it could be immediate and an early sign. Osteochondritis, again, it's inflammation and it could be an early sign. Hepatosplenomegaly also could be an early presentation. But saddle nose. Now, what does saddle nose require as a prerequisite? Now, saddle nose requires granuloma formation. And in granuloma formation, it takes time. So that is the reason why saddle nose is a late sign of syphilis and not an early one. In question 108, which of the following is not a cause of primary chronic mitral regurgitation? Now, whenever we hear the word primary, it means that the problem is with the organ in which the disease is present. So primary chronic mitral valve regurgitation, it means that the problem is in the mitral valve itself. So rheumatic fever affects the mitral valve. Infective endocarditis again affects the mitral valve. And radiation also predisposes damage to the mitral valve. But in case of ischemic cardiomyopathy, the problem is not of the mitral valve, but of the papillary muscles and the myocardium. So ischemic cardiomyopathy is a secondary cause of mitral regurgitation, and these are the primary causes. Question 109. Following clinical features most common associated with acute rheumatic fever in Indian population. So again, as a fact, the polyarthritis is the most common manifestation seen in Indian population. The erythema marginatum, subcutaneous nodules, and pulmonary hypertension are usually the late features
and usually less common than the polyarthritis. Question 110. 45-year-old male, sharp chest pain worsened by lying down. So this type of pain is either it could be like a pericardial pain or a pleuritic pain, relieved by sitting up. Recent viral illness. Okay. Friction rub is heard on cardiac auscultation. The ECG shows the following. So the ECG basically showed ST elevation, which was seen in all leads. So it was a global ST elevation. So global ST elevation, along with a pericardic chest pain, along with a viral illness and a friction rub. All of the following hint towards acute pericarditis. Also, one more thing, if you didn't know the answer, you could easily rule out the other options. Because we are seeing that recent viral illness is not associated with any of them. Also, aortic dissection, the pain would be interscapular. And it won't be relieved on bending forward. Also, there will be no friction drop in any of the other options. Question 111, 65-year-old man treated with PCI for STEMI develops syncope and is found to have 2:1 AV block with broad QRS on ECG. Which of the following is the most likely mechanism behind his AV block? How would atropine administration affect his condition? So in 2:1 block, we are either considering a Mobitz type 2 block or we are considering his Purkinje system block. Now we are given that there is a broad QRS. So it means that the block is below the level of the AV node. So it is a his Purkinje system block. And the atropine will improve? No, it will rather worsen, increase the degree of the AV block. Now this is due to a reflex mechanism. So the answer would be option 2. Sorry, the answer would be, just a second. The answer would be option 4. Now the reason that atropine will worsen the AV block is usually atropine is a drug of choice for bradycardia. So it seems counterintuitive, but on giving repeated dose of atropine, it will create a reflex response and heart will increase the AV block instead of reducing it. So the answer is option 4. It is the same mechanism which thiazide diuretic uses in case of diabetes insipidus. It will lead to a certain amount of volume depletion, but that small amount of volume depletion will cause the proximal tubule to reabsorb more water, causing improvement in the symptoms of diabetes insipidus. So it is more or less the same mechanism. Moving on to question 112. 50-year-old man presents with severe cough for 3 months, hemoptysis, and episodes for past 3 days. Physical examination shows hypertension, purple abdominal wall striae, changes in the hand as shown. Endobronchial lung biopsy is shown below. Which is the following the most likely diagnosis in this patient? So here the biopsy showed salt and pepper chromatin, which is suggestive of carcinoid. One of the close differential from this question could be oat cell or small cell lung cancer, as it can also show cushingoid features. But from the biopsy, it was evident that it is a carcinoid and not a oat cell cancer. Question 130. Which of the following dermatological disease is most specific for a patient of diabetes mellitus with RBS 220 and insulin and RIA showing low fasting insulin levels? So the insulin is low, but the blood glucose is high, which is classically seen in type 1 diabetes. So out of the given options, necrobiosis lipodica diabeticorum, it is typically associated with type 1 diabetes. So it would be the answer. Acanthosis is a problem of insulin resistance. So it is seen in type 2 diabetes. Whereas diabetic dermopathy is the most common finding. And intrateginous candidiasis is also seen in immunocompromised or uncontrolled glucose. So the most specific would be option A. 54-year-old female, significant weight loss, characteristic rash. Blood test reveals elevated plasma glucagon exceeding 1000. So it is clearly a glucagon producing tumor, most likely a glucagonoma. CT shows a large mass in the tail of pancreas, again suggestive of glucagonoma, because majorly the alpha cells which produce the glucagon are situated in the tail end of the pancreas. Which of the following statement regarding her condition is correct? The mass is commonly found in the head of the pancreas. No. Normally, insulinoma is found in the head of the pancreas. Initial treatment includes antibiotics and steroids. No, it is not an infective condition. Rash seen is necrolytic migratory erythema. Okay. Surgical resection is a treatment option for this condition. Again, this is an incorrect statement. So this happens to be option 3 happens to be the correct statement. The classical rash seen in glucagonoma is necrolytic migratory erythema. Again, a long question. Let's read the last line first. What is the main treatment he should consider if symptoms develop? 35-year-old mountaineer plans to do a rapid ascent of 4,500 meters. He has a history of experiencing symptoms like fatigue, non-productive cough, and difficulty breathing during previous high altitude trips. So we are talking about high altitude sickness or mountain sickness. Based on the scenario, which of the following strategies should the mountaineer employ to effectively prevent the symptoms? So let's read the option. Maintain an average altitude gain exceeding 300 meters and begin immediate treatment with acetazolamide. The last part is correct, but acetazolamide will take time to start working. So it will not begin the mechanism immediately. Also, we should gain less than 300 and not more than 300. So option 1 is incorrect. Option 2, ascend rapidly without acclimatization, use supplemental oxygen. So this is a blunder. This should not be done. Ascend slowly with maximum gain of 300. Prioritize descent of 1000 meters if symptom occurs. So this is the correct option. So basically, acetazolamide use is started 3 to 4 days prior to a mountain hike. So if any one of you has done a mountain hike which goes to like above 5,000 meters, from the base camp we start to have acetazolamide tablets for particularly people who are susceptible to such changes. So basically, acetazolamide takes time to relieve the symptoms. Use alcohol to relax during the ascent and rely solely on portable hyperbaric chambers if symptoms arise. So again, definitely this is one of the incorrect statement. Moving on to question 116. 65-year-old male, history of prior myocardial infarction, severe palpitation, dizziness, chest pain. Suddenly becomes pulseless, BP is unrecordable. ECG shows wide QRS, regular rhythm, and a ventricular rate of 160. So it is suggestive of VT, right? Ventricular tachycardia. As it is wide complex, ventricular rate is 160. Most appropriate treatment. Now here the BP is unrecordable, so the patient is collapsing. So in severely hypotensive patient or in collapsing patient, we directly go for defibrillation. We do not go for any of the pharmacological management. 58-year-old male with CKD returns for a follow-up reporting fatigue, bone pain, muscle weakness. Examination reveals bone tenderness. Lab test showed elevated parathyroid levels, which of the following is not typically associated with this condition. So this is secondary hyperparathyroidism, secondary to CKD. Elevated serum calcium, okay, this would be seen. We are asked which will not be seen. Raised serum alkaline phosphatase, again, this would be seen. Elevated serum phosphate, okay. Raised urinary albumin to creatine ratio. So elevated serum phosphate would be seen, but urinary phosphate would be low. So again, this would be seen, this would be seen, this would be seen, but this would not be seen. There is no problem in albumin or creatine ratio. So basically what happens is in CKD, the body is unable to excrete phosphate. So the phosphate accumulates in the blood. And along with that, there is hyperparathyroidism, which causes an increase in serum calcium level. Now, whenever serum calcium is taken from the bone, the enzyme which is involved also releases ALP. So also there would be elevated ALP levels, elevated calcium levels, and elevated phosphate in the blood, suggestive of secondary PTH due to CKD. Also, in the X-ray, classical Rugger Jersey spine would be seen in the X-ray.
So here the correct answer would be option 4. Which of the 50-year-old woman presents with increase in the size of hand and feet with voice changes and carpal tunnel syndrome, IGF-1 is increased? Which of the following findings will likely not be seen in this case? So this is the case of acromegaly, as we can see from the raised IGF levels and also the symptoms: hypoglycemic attacks, galacturia, bitemporal hemianopia, and colonic polyps. So hypoglycemic attacks will be not seen in case of acromegaly because this would be due to raised growth hormone, raised growth factors, and insulin-like growth factor would also promote increase in blood glucose. So don't get misled by the name insulin-like growth factor. It actually does not work like insulin. It does not reduce the blood glucose. Instead, it increases the blood glucose. The answer over here would be hypoglycemic attacks. Question 119. RAIU scan was performed on a 35-year-old lady with hypertension and palpitation. And we are asked about the diagnosis. So the iodine uptake scan showed diffusely enlarged and high uptake in the entire thyroid gland. So in toxic multinodular goiter, we will see high uptake in certain regions of the thyroid and not diffusely in the entire thyroid. In Graves' disease, there would be a diffuse increase in the uptake of radioiodine, which was shown in the image. So option 2 would be the correct answer. In thyroiditis, there will be a reduced uptake as there is thyroid inflammation. And in thyroid adenoma, there would be a single region where there would be high uptake of iodine. Question 120. 28-year-old male admitted to the ICU after sustaining blunt chest trauma in a motor vehicle accident. Chest imaging reveals pulmonary contusions. After 48 hours, he developed severe hypoxemia with PaO2 or FiO2 ratio 110. So this suggests severe ARDS like picture. Bilateral infiltrates on chest X-ray, no signs of the left heart failure. So whenever we are suspecting ARDS, it is important that we rule out any cardiac pathologies because cardiac pathologies would also lead to infiltrates in the chest X-ray. However, in case of heart failure, the infiltrates would be spread in a battering fashion. What is the most appropriate next step in the management? So in case of ARDS, we always prefer a low tidal volume, high PEEP ventilation or a prone ventilation, which is a lung protective ventilation. Insert wide bore needle in the fifth intercostal space. This is done in case of pneumothorax, which could be the reason because of the trauma, but the symptoms and the clinical progression does not match. Start IV furosemide to reduce the pulmonary edema. Now, this is the difference I was talking about. If we suspect a patient of heart failure, and if the pulmonary edema is due to heart failure, it will show battling appearance, and in that, furosemide might be effective. Begin low tidal volume mechanical ventilation. This is absolutely correct option. Initiate high flow nasal cannula oxygen therapy. There will be no point in giving oxygen as the lungs are filled with fluid. It's always better to begin low tidal volume mechanical ventilation, followed by increasing the oxygen. The Leifson and Ryu stain is used for staining which of the following? So I guess there was an image along with this question. However, if the image would not be there, even though we can still solve the question. The Leifson and Ryu stain is used for the staining of the flagella. So option 3 would be the correct. It's a basic one-liner. Question 122. Which statement is not true regarding the Kirby-Bow disc diffusion method? Apply 4 to 6 antibiotic discs per 9 centimeter. Okay, I don't know about this, so let's keep it as a potential option. Factors such as nature and composition of the medium can influence the zone diameter. This sounds to be correct. Okay. Incubation is typically done overnight. Okay, again, this sounds to be correct. This concentration does not affect the zone of inhibition of the diameter. Now, this seems to be more incorrect. So I will go with this option. The reason is the disc concentration will definitely affect the zone of inhibition. If there is a higher concentration of antibiotic, it will cause a higher zone of inhibition.
So the option would be option 4. Question 122. Which among the following is not true regarding gas sterilization? Mechanism of bactericidal action in alkylation. Okay, it seems true. Used to sterilize cardiopulmonary machines. Okay, again, it seems to be true. Refers to ethylene oxide ideally used at 55 to 60 or 4 to 12 hours. Okay, this also might be true. Suitable for fumigation of OT complex. Now, this I definitely know that it is not a true option. As in OT complexes, we usually use formaldehyde and fumigation rather than gas sterilization. As it is a highly volatile gas, we would not like to use it in the fumigation of the OT complexes. Question 124. 62-year-old female with a history of rheumatic heart disease and prosthetic mitral valve undergoes a tooth extraction. 2 weeks later, she presented with fever, night sweats, and malaise. Blood culture reveals alpha hemolytic strep viridans. Transesophageal echo shows vegetation on the mitral valve. Which of the following is the best next step in management? Start oral amoxicillin and follow over 1 week. The patient has already developed mitral vegetation and infective endocarditis, so oral antibiotics would not be preferred. Admit to hospital and start IV ceftriaxone and gentamicin. This seems to be the correct option. Discharge with a prescription for oral clindamycin and instruct her to return if symptoms worsen. Again, in a case of existing infective endocarditis, I don't want to send the patient home and give oral medication. Schedule urgent valve replacement surgery. Again, this would be a very radical step in the treatment. Instead, I would like to admit the patient to the hospital and start IV antibiotics, especially ceftriaxone and gentamicin. Question 125. Patient presents with severe swelling of the neck along with difficulty in swallowing. On examination, there was a grayish-white pseudomembrane. Again, this is a buzzword. This is a giveaway for Corynebacterium diphtheria. Also, let's read the question further. Which of the following bacteria is most likely responsible for the clinical findings? So, Corynebacterium diphtheria, it is the answer here because gray-white pseudomembrane in the throat is the classical buzzword. Question 126. 29-year-old male presents to the emergency department with high fever, chills, and a painful swelling in the axillary region. Reports he recently returned from a trip to Himachal Pradesh. On physical examination, a large tender lymph node is noted in the axillary region. Aspirant is stained with methylene blue and is shown in the image below. Which of the following organism does not show a similar typical appearance as seen in the image? So, if the image is shown, it would have been more helpful, but seeing the answer, the answer is given as Clostridium tetani. It's a gram-positive anaerobic bacillus that form the terminal spore. The appearance is due to spore formation and not bipolar dye uptake. So basically, it seems that we were asked about an organism which shows bipolar staining, and Burkholderia, Pseudomeli, Vibrio parahemolyticus, and Klebsiella granulomatis. All these 3 organisms does show bipolar staining, whereas Clostridium tetani does not. Moving on to the next question, 65-year-old male present with severe abdominal pain and elevated liver enzymes. After imaging, he is found to have suspected bile duct obstruction due to a stone. The physician plans to both visualize and potentially treat the obstruction. Which imaging modality should be chosen? Now, whenever we want to see the image as well as we want to do an intervention, it is always ERCP better than MRCP. As in MRCP, it's just a T2, highly T2 weighted image, which causes the delineation of the bile ducts, but we cannot do any intervention. Whereas in ERCP is a gold standard, as we can do both diagnosis as well as the treatment along with it. Question 128, 35-year-old female scheduled for ERCP using a contrast mentioned below. Which of the following is a type of contrast agent? So as far as I remember, it was iohexol contrast. Whenever you see a contrast name ending with 8, it means it is an acid, which means it is an ionic dimer. So iohexol does not have 8. In fact, it's an alcohol, so it's a non-ionic compound, and it's a non-ionic monomer. As there is only one non-ionic dimer whose name starts with di. So you can look up
to that in the theory, but iohexol is definitely a non-ionic monomer. Question 129, it is for the match the following. So let's highlight. So first of all, let's see which options we are sure about. So for a fact, I know that in acute epiglottitis, I would be having the thumb sign. So D is 5. Now, can we rule out any options? I think we can rule out these two options. Option 4 is cut below. Then aspergilloma, which shows a air crescent sign. So B is 4. B is 4. Then in case of Klexilla pneumoniae, we see a bulging Fisher sign. So again, A is matching with 3. B is 4. Staphylococcal pneumonia, we classically see a air bronchogram sign due to consolidation. And E is 1. Pneumocystis, we see a reticular shadow, which shows atypical pneumonia. So the correct option here is option 2. Question 130, structure primarily responsible for offering resistance. Which structure primarily offers resistance to aqueous humor outflow within the iridocorneal angle? So let's suppose this is the cornea and this is the iris. Since iridocorneal angle, we will have the trabecular meshwork, which when if it gets blocked, it leads to open angle glaucoma. But when the iridocorneal angle reduces, it results into a closed angle closure glaucoma. So the correct answer is trabecular meshwork. 131, again a long stem question. Which of the following features is not typically seen in this patient? 35-year-old male, emergency department, chronic abdominal pain, fever, unintentional weight loss over the past month. He reports altered bowel habits and has a history of exposure to individuals with TB. Small bowel follow-through imaging is provided below. Based on the clinical presentation and the attached imaging, which of the following is not seen? If we're talking about TB of the intestine or intestinal TB. So in case of intestinal TB, spasm and edema at the ileocecal valve is usually seen. The ileocecal valve is the most common site of intestinal TB. Uniform thickening of the entire colon, it is not seen. It is irregular thickening. Presence of mesenteric adenopathy is definitely seen. Sterling sign with rapid barium emptying is again seen. So the uniform thickening of the entire colon is not seen. There is patchy thickening of the entire colon. With eye syndrome is characterized by the presence of pigmented nodular lesion in the iris. Again, these types of questions are the bouncer question. If you have not read about these questions, it's better to leave these questions. The fact for this question is the eye syndrome is related with the Cogan-Rees syndrome. So there is no hi-fi concept behind this question. Question 133. 32-year-old immunocompromised patient living with cats. Present with decreased vision in the left eye. On examination, she has mild anterior uveitis with vitritis, and fundoscopy image is shown below. So the image shown was showing the headlight in fog appearance. And with the given history of immunocompromise and the close proximity with cats, we could easily identify the disease to be toxoplasma even without the image. But in case of toxoplasma, classically, we see a scar if it is chronic, but in acute phase, we could see the headlight in fog appearance. Whereas in case of cytomegalovirus, we see a pizza pie appearance. 134, which of the following arteries contributes to the formation of circle of Zinhalen? Now, even like I don't know this question, and you can easily rule out the other options. Like central retinal artery and ophthalmic artery will go inside the eye and supply the supply the globe of the eye. So definitely they cannot be involved in the circle of Zinn anastomosis. Whereas short posterior ciliary artery is the answer of this question, and it is related for circle of Zinn artery.
Which of the following condition is most commonly associated with the development of beaten metal appearance in cornea? Now, beaten metal appearance is a classical buzzword for Fuchs endothelial corneal dystrophy. You could easily rule out keratoconus as there is like no beaten metal appearance. We see like the coning of the anterior cornea. But again, ophthalm is a more of a fact-heavy subject, so there is no concept behind this fact. Moving on to question 136, which device is a non-contact tonometer based on the principle of corneal hysteresis? Now, as we know that Schiot's and Goldman appellation tonometer are contact tonometers. So both of them are ruled out. Now, confusion might arise between ocular response analyzer and pneumatometer. So pneumatometer is a non-contact tonometer, but it does not follow the principle of corneal hysteresis. So also that is ruled out. So the correct option is option 3. Now, if you don't know this question, you could easily rule out option 1 and option 2. As the name itself suggests, appellation tonometer. And Schiot's you must have like used in your internship, like Schiot's tonometer. Both of them are definitely contact tonometers. And after ruling out the two options, you could take an educated guess between option 3 and 4. Question 137. What instruments are used during a cesarean section? So BP handle will obviously be used to make an incision. Doyle's retractor to retract the bladder. Cusco speculum is not used. It is used to take pap smear. It is a self-retaining speculum. Alice forceps is again used. And green Armitage forceps is used to catch the angles of the uterine incision. So 1, 2, 4, 6 are used. So option 3 is the correct option. Again, Shirodskar's uterine clamp is not not the instrument which is used in cesarean section. 138, a 45-year-old male presents with progressive abdominal discomfort and weight loss. Endoscopy reveals a gastric mass. Biopsy confirmed diffuse gastric carcinoma. Which protein is responsible for maintaining cell-to-cell adhesion and inhibiting the cell motility is most likely mutated in the condition. So the image had shown signet ring cells. Now, even without the image, just from knowing that it is a diffuse gastric carcinoma and the cell which is responsible for cell-to-cell adhesion, we could come to the answer of E-gathering. There is a CDH gene mutation, and mainly two cancers are associated with CDH mutation. The first is diffuse gastric cancer, and the second is lobular cancer of the breast. Moving on to the next question. Individual living with HIV infection, which hematological abnormalities observed most commonly? So all of these may be observed in a patient of HIV, but the most common always happens to be the anemia. The basic reason or the fundamental concept is as the RBCs are produced the most in the bone marrow, if any problem occurs in the bone marrow suppression, the thing which is produced the most will be the most commonly affected. So by that logic, the anemia would be the correct answer. Question 140, 28-year-old woman is noted to have extraglandular tissue in her axilla that becomes tender during her menstrual cycle. Regarding accessory breast tissue, which of the following statement is incorrect? It can respond to hormonal changes such as menstruation or pregnancy. This is correct. It is synonymous with supranumerary nipples. So this is wrong. Mammary tissue and having an extra nipple is two completely different things. It can rarely be found along the chest wall or abdomen. This is again correct. Actually, in the body, there is a milk line which extends from the axilla. So basically, this is a thorax, this is the head, this is the legs, arms. Basically, this is the thorax of the person, and the milk line extends from the axilla to the inguinal region. And along the milk line, there is usually the development of mammary tissue and the nipples. So basically, in the lower mammals, such as cats and dogs, there are multiple mammary glands and multiple nipples. But in case of human, only the chest region will produce a pair of mammary glands. So basically, the other mammary glands will regress. But sometimes in the axilla, there might be accessory mammary tissue, which will react to the hormone, which will be found along the chest wall or the abdomen, and surgical removal may be considered for cosmetic or symptomatic reasons, as there is no
need, like there is no risk of developing into a cancer or anything. But it's not synonymous with supernumerary nipple. Moving to question 141, 22-year-old woman presents with firm, mobile, well-circumscribed breast lump measuring 2.5 centimeter. Ultrasound confirms a typical fibroadenoma. She has no family history of breast cancer. Which of the following best describes the underlying pathological processes of fibroadenoma? So basically, there is hyperproliferation of the fibrous tissue in the breast, right? So hyperplasia of breast lobule seems to be correct option. Malignant transformation is not seen as the mass is firm, mobile, and well circumscribed. Also, there is no history of breast cancer in the family. Cystic degeneration or inflammatory infiltration is again not suggestive seeing the clinical picture. So hyperplasia of breast lobule fits perfectly with the fibroadenoma. What is the diagnosis of a patient who has history of smoking 24 packs, is currently experiencing breathlessness, chest pain, is found to have a lung tumor with positive chromogranin? So as we know that chromogranin, synaptophysin, they are present in small cell cancer or any cancer with a small round blue cell tumor, such as small cell cancer. So chromogranin, synaptophysin, bombesin, they are the markers which suggest a tumor of neuroendocrine origin, such as the small cell carcinoma. 143, a patient with autoimmune thyroid disease is suspected to have autoimmune polyendocrine syndrome type 2. Which of the following pairs of additional disease, when present together with autoimmune thyroid disease, would confirm the diagnosis of APS2? Hypoparathyroid and chronic mucocutaneous candidiasis. This suggests APS type 1. Whenever you hear candida along with autoimmune thyroid and hypoparathyroidism, think APS type 1. Whereas if you see Addison and type 1 diabetes, it is classically associated with APS type 2. Pernicious anemia, vitiligo, celiac, and Sjogren's. These are also autoimmune conditions, but they are not in the spectrum of APS1 or APS2. Question 144. A child is brought for medico-legal age assessment. The X-ray of the hand is shown, which is the most likely age of the child. So in the X-ray, we had seen like different carpal bones. So just to revise the carpal bones, the first carpal bone to appear is the capitate. You can remember it as the captain of the team. So first, always the captain will come. Second would be the hamate, which you could think about as the vice captain. Then triquetrum, as the name says, tri, so it comes in the third position. Then would be lunate. So you could easily convert lunate into a 4. So it would be the fourth to appear. Then would be scaphoid. So you can easily convert the S into a 5. Then trapezium and trapezoid. Both will appear together. And pisiform is the last bone to appear. Right? And it's a sesamoid bone. The ossification happens in the tendon of extensor carpi ulnaris. Right? Sorry, flexor carpi ulnaris. Right? So this is the sequence, and 3 bones were shown. So the age would come out to be 3 years. Question 45. Again, the bones, the teeth, they are really important with regards to FMT. So again, you should revise them near to the exam. Question 145. During autopsy of a suspected suicidal drowning, skin over the palms and soles appear pale, wrinkled, and sodden. Now, what is this describing? This is describing classical case of washerwoman's hand, right? Which of the following statement regarding this finding is correct? Confirms the death occurred only a few hours earlier. Okay. The timing of development varies with environmental condition. That is correct. Change is first noticed over the dorsum of the hand. That is incorrect. Synonymous with goose flesh. It is incorrect. Goose flesh is nothing but piloerection. And it does not confirm that the death occurred only a few hours earlier. So the right option would be option 2. It would depend upon the environmental condition, how much moisture there is, how much temperature there is. So option 2 is the correct option. 25-year-old male present with fall of the shoulder. X-ray shows the fracture at the junction of medial 2/3 and lateral 1/3 of the clavicle.
So also mark that this is the most common site of clavicle fracture, and clavicle happens to be the most common bone to be fractured in adults as well as in neonates during delivery. The lateral fragment is displayed inferiorly while the medial fragment is elevated. Most likely reason. So during the clavicle, when the clavicle bone is fractured, the weight of the arm pulls the lateral fragment below, whereas the sternocleidomastoid, it pulls the medial segment above. So pull of trapezius on the lateral fragment, it is wrong. Pull of pectoralis major on the medial fragment, again it would pull it medially and not superiorly. Weight of ipsilateral arm and pull of sternocleidomastoid, this is exactly the reason. And spasm of the deltoid muscle again is a wrong statement. Drug administered orally, plasma concentration time curve is plotted. Which pharmacokinetic parameter best reflects the total amount of drug reaching the systematic circulation? So let's plot it. So this represents the time to reach the maximum concentration. This is the concentration maximum. And what I'm highlighting is the area under the curve. Now we are asked about the total amount of drug reaching the systematic circulation. Now you can smartly eliminate the options by just looking at the values we are given. Here it is talking about concentration. Now the unit of concentration would be milligram per liter or milligram per dl. It is not representing the total amount. Again, it is concentration. Again, it is half-life, so it would be in time, like milliseconds, seconds, minutes, hours. So the only option which makes sense is the area under the curve, right? You could easily eliminate the first two options without knowing anything about the question. Question 148, which of the following drugs is unsafe in pregnancy as it crosses the placenta? So heparin, as we know, heparin is a large molecule which is negatively charged, so it cannot cross the placenta. Insulin again is a large protein which cannot cross the placenta, and that is the reason we give insulin to the GDM and the females having diabetes. So the blood glucose is controlled in the female, but it does not crosses the placenta and affect the fetus. Whereas glycopyrrolate, again, it is a quaternary amine, so again it cannot cross the placenta. Whereas dexamethasone, now even logically thinking, dexamethasone is the only drug which we use during pregnancy to with the aim that this drug should reach the fetus, as our aim is to get the fetal lung maturity, right? So it definitely crosses the placenta, but it is unsafe or safe. It depends when you use it. In the later part of the pregnancy, when we want lung maturation, it is safe and it is therapeutic. Whereas if you use it in the early pregnancy, it could cause HPA axis suppression. Question 149, what is the most common subtype of Hodgkin lymphoma? So as we know that mixed cellularity is the most common in India or in Asian subcontinent, whereas nodular sclerosis is the most common overall. So nothing for India is mentioned, so I will go with option C, nodular sclerosis. Question 150, during an oral examination on sarcomere structure, a student asked to identify protein that constitutes the thin filament of the skeletal muscle. One of the listed options is incorrectly included in the component of the thin filament. Which of the following are the components of the thin filament? So as we know, troponin, tropomyosin, and actin are all the part of the thin filament. So actin is the main base on which troponin C, troponin T are present on it. And tropomyosin is a ribbon-like structure which covers the myosin binding sites on the actin molecule. But myosin is considered in a thick filament, so 2 will not be in the option. So the options we need to search is 1, 3, and 4. Option 3 is 1, 3, and 4, and that happens to be the correct answer. So again, let's take a quick 2-minute break and drink some water, do some stretching, and we will meet after 2 minutes for the last lap of the discussion.
Okay, so let's start with question 151. A non-hemolytic, non-motel catalase positive, gram-positive rod is isolated from a patient with suspected respiratory distress. When specific agent is applied to a blood agar plate with isolate, the result is as shown in the image, which test is being demonstrated. So basically, the image showed a gamma phase lysis assay, and from the clinical stem, you might have guessed the organism to be Bacillus anthrax. Now, in Bacillus anthrax, we can see the McFadden reaction, but that is for the capsule. By the way, the capsule of Bacillus anthrax is an exception. It is formed by poly D-glutamate. It's a polypeptide capsule as compared to the polysaccharide capsules of other organisms. String of pearls appearance is also seen in B. anthrax. A specific image was showing a zone of clearance and which suggested gamma phase lysis assay. Question 142. A 2-year-old child is brought to the clinic with a puffy face, edema of the feet, enlarged abdomen. Child has been fed mostly starchy food like rice, porridge with very little protein. So we can see that there is no calorie deficit, but there is a clear protein deficiency. Laboratory test reveals low serum albumin. What is the most likely diagnosis? Now here there is isolated protein deficiency, so the answer is kwashiorkor. In kwashiorkor, we could also see flaky pate dermatosis, flag sign, pot belly, and the appetite would be low. Whereas in case of marasmus, it would be voracious appetite. The uh, the appearance would be baggy pant appearance. The face would be simian faces or the face of an older person. So these are the differentials. Question 153. 18-year-old girl presents with gradual blurring of vision and glare. Slit lamp shows multiple fine polychromatic needle-shaped refractile crystals in the lens cortex giving sparkling appearance. Which systematic association is most likely seen? Now, in Alport syndrome, there will be anterior lenticonus. Sorry, in Alport, that would be in Lowe syndrome. The image here was showing a Christmas tree cataract, and the Christmas tree cataract is classically seen in myotonic dystrophy. So Lowe syndrome, we see anterior lenticonus, and in diabetes, we see the snowflake cataract. The axial CT scan of the chest shows thick-walled, centrally located cardiac chamber marked in the image. So in the image showed the left ventricle to be the mark. So basically, how to rule out option? It is said centrally located. So even without the image, I could rule out right ventricle and left atrium. The reason being the left atrium is the most posterior chamber, whereas the right ventricle is the most anterior chamber. Question 155. Vessel marked in the angiographic image supplies the lateral surface of the cerebral hemisphere. So also without seeing the image, the lateral surface of the cerebral hemisphere is supplied by the middle cerebral artery. Whereas the inferior and the anterior strip is by the anterior, whereas the posterior is by the posterior cerebral artery. Also, the image showed an arrow clearly pointing towards the middle cerebral artery. So you can see that even without the image, just by reading the question, we could come to an answer. Which of the following statement regarding the arrangement of cutaneous blood vessels is incorrect? Arteries entering the skin from deep faciovascular plexus. Okay, I don't know about this statement. Ascending arterioles gives rise to subpapillary plexus. This seems to be correct. Capillary loops extend into papillary dermis between the lateral ridges. This is definitely correct. As if you might know, in case of psoriasis, we do a test in which we start to scrape off the excessive plaques, and then we see pinpoint bleeding. So that is exactly the capillary loop which have extended into the papillary dermis, which we are seeing. The blood vessels are present within the epidermis. Now, this is definitely the correct answer and the incorrect statement. Because just imagine if blood vessels would be in the epidermis, then just a minor scratch would lead to a lot of bleeding. So the blood vessels are not in the epidermis, they are in the dermis.
Which of the following statements is false regarding the condition shown in the image below? So basically in the image, it showed a penile lesion, which were pearly papules seen on the shaft and the glands of the penis, and it was a benign anatomic variant. Okay, we are supposed to see the false statement. So the false statement would be caused by human papilloma virus. So human papilloma virus, it causes condyloma and not the papules which were shown in the image. So it is a benign variant, no itching or pain, and reassures the treatment. All of them are correct. 45-year-old male believes that the local police and his neighbors are conspiring to poison his food and spy on his activities despite having no evidence to support his claim. Now, what is this? This is the delusion of persecution. Which of the following statements regarding this condition is true? It is the most common type of delusion. It is true. Disorder of thought possession. Okay. The belief that a familiar person has been replaced. This is false. Exclusively seen in schizophrenia. It is again false. And disorder of thought possession, it points towards obsession and not delusion. So it is the most common type of delusion. It is the correct statement. So option 1 is the correct answer. Question 159, 40-year-old male, history of head trauma, comprehensive evaluation of determine the presence and lateralization of organic brain damage. Psychologists administered fixed test sets, including the category test, rhythm test, to calculate the impairment index. The assessment tool best identified is. Now, even if we don't know any of this test, I don't know any of this test, but I can remember that if the patient is going to a psychologist, an ink blot test, Minnesota multiphasic personality inventory, and thematic appreciation test. The common point in all of these tests are the patient is shown some images or some patterns, and then according to the patient's personality, the patient answers what the patient see in the image. So here they show different shapes of ink blots, and if one patient is in very good mood, he might say that he's seeing a butterfly. But if the patient is not in a good mood or he is having constant negative thoughts, the same butterfly would appear to be a scary looking face to another patient. In the Minnesota Multiphasic Personality Inventory, it itself says that it is a personality test. In thematic appreciation test, we usually see that can the patient appreciate the theme which is shown in the image. None of this is used for organic brain damage, right? So I am not aware about this option, but I could easily mark option 2 because I could arrive here with the trick of elimination. Also, it is a big question mark that why after such a head injury the patient has gone to his psychologist, right? Anyways. Question 160, a patient with intensely pruritic excoriated papule shown in the extensor surface and granular IgA dermal papilla on direct immunofluorescence. Which drugs provides rapid symptomatic relief? So here the answer is Dapsone. We can see it is IgA dermopathy, which is also seen in gluten sensitivity or celiac disease. Question 161. Therapist treats a child's cynophobia by first demonstrating safe interaction with the animal, then physically guiding the child to touch it. This technique is best classified as. Now, there might be a confusion between option 1 and 2. First, let's rule out option 3 and 4. Aversion therapy is something which is done where we don't want to promote a certain kind of behavior, such as in alcoholics. So that is out. Flooding. In flooding, we provide the patient with a high dose of a stimulus of which he is afraid of. For example, if someone is afraid of water, we just throw the person in the swimming pool. So that is flooding. That is obsolete now. No one does it. So also that is out. Now, what happens is systematic desensitization is you show the patient something which he or she is afraid of. For example, in this case, the person is afraid of this animal. So you bring the animal, keep it in front of the patient, and then you start to tell the patient to relax his toes, to relax his calf, to relax his thighs, and slowly, slowly you tell the patient to relax and get comfortable and sensitized towards the fears. But it's participant modeling. This is what is shown in this example, where the participant, which means the patient, is shown what he has to do by modeling the fear. So, for example, if someone is afraid of dark, the examiner will put himself in a dark room and will encourage the patient that if nothing has happened to me, nothing will happen to you also. So, this is a classical example of participant modeling, in which first demonstrating safe interaction with the fear, it could be any of the fear, and then physically guiding the person to overcome the fear, right? So this is a classical example of participant modeling. 162, which of the following primary malignancies typically produce purely osteolytic wound? Now, as we know that prostate cancer, it produces mainly osteoblastic, but it could also produce osteolytic. Similarly, medullary carcinoma also produces both. Breast carcinoma produces osteolytic more than osteoblastic, but still it has both the lesions. But renal cell carcinoma, it's a highly vascular tumor and it only produces purely osteolytic metastasis. Moving on to question 163. A patient is started on a continuous IV infusion of a drug Z at a rate of 180 milligram per hour. The drug has systematic clearance of 300 ml per minute. Assume linear kinetics. What will be the steady state plasma concentration of the drug? Now, as a fact, we know that at steady state, the input should be equal to the output, right? So here, how we will approach this is that first we'll calculate the rate of input, which we know is 180 milligram per hour. And the clearance is given us in terms of minute. So first we'll change the units. If here we want to have the units as minute, we need to divide both sides with 60. So it will turn out to be 3 milligram per minute. So this is the rate of infusion. So the input is 3 milligram per minute. The output would be clearance into the steady state plasma concentration. So clearance, which we are already given as 300 ml per minute, into the steady state plasma concentration. Now the plasma concentration we are given in milligram per liter, and here we have the clearance in ml. So we need to convert it into liter. It would be 0.3 liters per minute into plasma concentration. Here it is 3 milligram per minute. So the plasma concentration turns out to be 3 divided by 0.3, and the minutes will get cancelled. It will come out to be 10 milligram per liter. Option 3 would be the correct answer. Coming on to the question 164. 48-year-old woman with osteoarthritis started on NSAID for chronic knee pain. During pharmacology discussion, a student makes several statements regarding the mechanism of action of NSAID and related enzymes. Which of the following is correct? COX-2 is constitutively expressed on gastric mucosa. That's incorrect. COX-1 is. NSAID primarily inhibits phospholipase 2 and reduce prostaglandin synthesis. It is again incorrect. Steroids inhibit the phospholipase 2. COX-1 is constitutively expressed and involved in physiological function. That is a correct statement. Whereas lipoxygenase inhibition is principal mechanism of action of traditional NSAIDs. No, it is the mechanism for drugs like leukotriene, which block the receptor, whereas xylitol will block the lipoxygenase pathway. 165, 55-year-old patient evaluated for potential diuretic therapy. Which of the following conditions are thiazide diuretic generally not indicated? So as we had discussed in a question in the earlier section, in the first section, hypercholesterolemia is a condition in which you not give thiazide, as thiazide in itself will cause hypercholesterolemia. It will cause hyperuricemia. It will cause hyperglycemia. So we will not use diuretic thiazide in these. Whereas in case of nephrogenic diabetes insipidus, thiazide is a drug of choice. Congestive heart failure, we can again use thiazide. However, furosemide, which is a high ceiling diuretic, will make more sense. Thiazide is usually used in patients of hypertension. Idiopathic hypercalciuria. So there is increased calcium in the urine. So thiazide will cause reabsorption of the calcium from the urine. As we remember, loop loses calcium, but thiazide reabsorbs calcium. So it can be used in hypercalciuria. So the interesting point is, in case of nephrogenic diabetes insipidus, the patient is already losing a large amount of water. So now, why we want to add a thiazide, as thiazide is a diuretic, and diuretic causes increase in the urine production. Now here the mechanism is that whenever body is already losing a large amount of water, now if you will give thiazide, body will lose even more water, but that will reflexly cause the body to realize its mistake, and from the proximal part of the nephron, it will start to absorb more water. So in this case, thiazide is a drug of choice of nephrogenic diabetes insipidus. Question 166, health adjusted life expectancy estimates. Life expectancy at birth, it is seen in HDI, whereas life expectancy at 1 year is seen in PQLI. Here, the newborn is expected to live in full health based on current rates of ill health and mortality. This is the correct statement. This is actually the definition of age. Disability-free life years, it is DFLE, whereas years lost to premature death, it is YLL. Patient from endemic region undergoes abdominal ultrasound for a cystic lesion of the liver. Ultrasound shows the image below. The image was of honeycomb appearance of liver. So we are thinking in terms of hydrated disease. According to the WHO ultrasound classification of hydrated cyst, the pattern demonstrated here is categorized as which of the following. So honeycombing is CE2, which is also equal to Garvey class 3. Which of the following is not classified as a peripheral membrane protein? Now here's the important concept. For example, this is the phospholipid membrane. The proteins which are just on one side of the membrane are called as peripheral proteins, and the proteins which are crossing the membrane on both the sides, they are known as the intrinsic proteins. So sodium potassium ATPase, it is definitely intrinsic protein. Insulin receptor, it is also intrinsic protein. G protein coupled receptor are they cross the plasma membrane 7 times. Heptahelical, they are also intrinsic protein. And cell surface receptors are also intrinsic protein, which has one part outside and the other part inside. So 1, 2, 3, 4, we are asked not classified as peripheral protein. So each and every one of them is intrinsic protein and is not classified as a peripheral protein. 169, pralidoxime improves muscle weakness in organophosphate poisoning, which seems to be correct. Pralidoxime reactivates acetylcholinesterase by removing the phosphate group from the inhibited enzyme before aging up. That is definitely correct. So both are correct, and R is the correct explanation of the assertion. During microscopic evaluation of ovary, a pathologist identified small fluid-filled spaces surrounded by granulosa cells. Which of the following characteristic of a developing Graafian follicle? What are these structures called? So as we know, granulosa cells, the tumor we are talking about is granulosa cell tumor, and the bodies we see are colexinal bodies. Schiller-Duval bodies are seen in yolk sac tumor. Samoma bodies are seen in squamous cell cancer, and Ranki crystal are seen in Leydig cell carcinoma. 45-year-old woman. Okay, so first we'll see what's being asked. We are asked the diagnosis again of gallbladder. 45-year-old woman present with gradually enlarging, painless right upper abdominal mass. Examination reveals a smooth, non-tender bladder. So again, non-tender will rule out acute cholecystitis, right? And carcinoma can also be ruled out because it is a smooth, non-tender, below the right prostate margin, afebrile, anictric. Again, chronic cholecystitis is out. Liver function is normal. USG shows markedly distended, thin-walled bladder filled with clear fluid, and a gallstone impacted in the neck of the gallbladder. So it is classically talking about a mucosity where there is a clear fluid accumulation. which is caused secondary due to a gallstone obstruction. For a monovalent positive ion +1, the extracellular concentration is 80 and the intracellular concentration is 8. What is the equilibrium potential at 37? So in such type of questions, I don't like to remember the formula. Rather, I go with a very simple rule. So assume this is the plasma membrane, this is the interior of the cell, this is the exterior of the cell. As we know that the concentration on the exterior is higher and the concentration of interior is lower. So where would the ion would love to move? The ion would love to move into the cell. So to maintain equilibrium, so there are two forces. The osmotic force will push the ion inside, whereas the electrochemical force must push the ion outside to attain a equilibrium. So it is a positive ion. So if we create a positive environment in the cell, it will repel the ion and both of them will balance out. So first we will rule out the negative ones. Now we are remain with two positive options. Now in any such question, we know that it starts something with +61, then logarithmic concentration outside upon concentration inside, right? So this is the formula. So plus minus 61 log of 80 by 8, which comes out to be 10, which comes out to be 1. So the answer would be plus minus 61. And we are already sure that the sign over here is plus. So the answer would turn out to be plus 61. If you don't want to remember the formula, just remember that whenever it is given in the multiples of 10, we will always multiply with 1. And usually the examiners will ask either multiple of 10 or the multiple of 100, in which we will have log 100, which is equal to 2. Let's go to question 173. 31-year-old pregnant woman at 20 weeks of gestation undergoes routine scan. The USG depicts the following findings as shown in the image, which was the following the most likely diagnosis. So the image clearly showed anencephaly, which is a missing calvaria or the missing skull in the USG. The answer would be anencephaly. Question 174. Which part of the neuron normally contains highest density of voltage-gated sodium channels responsible for rapid impulse? So again, we are given a history which is of no importance. We are just our highest density of voltage-gated sodium. So whenever we have a neuronal membrane, we have this myelin sheath. And in between the myelin sheaths, we have nodes of Frederick, which contains a high amount of sodium channels, which are used for saltatory conduction. So nodes of Frederick, option 4 is the correct answer for this question. Question 175. Again, it's a match the following. So Spiegelberg, Sturdyford, and Rubin's. So how I remember this fact is Rubin's criteria. Rubin's, if you have seen the instruments, there is a Rubin's cannula which goes and sits near the cervix. So in Rubin's, it is the cervical pregnancy. So 3 is 1. So by only knowing this, we could rule out other options. Also, Sturdyford, it causes abdominal pregnancy. So 2 is 3. And Spiegelberg is for the ovarian pregnancy. Now, one question I would like to ask is that which of these ectopic pregnancy would go till term? Would it be a Sturdyford, Rubin, or Spiegelberg? Which pregnancy could go till the term? So the answer of this question is Sturdyford. Yes, someone correctly said the answer is Sturdyford because only abdomen will provide the space which is required for the entire fetus. So the Sturdyford pregnancy or the abdominal pregnancy will go till the term. What is the recommended treatment for a pregnant woman diagnosed with early syphilis? Benzazine penicillin 2.4 million, single injection. This seems to be correct. Aqueous crystalline penicillin. This is used in neurosyphilis. This is the incorrect statement. Benzazine 2.4, 3 doses. Again, it is in the secondary and the tertiary syphilis. So this is again correct. Incorrect. Oral doxy is again incorrect. So benzazine penicillin, single ion injection will be the correct statement. Patient with thyroid tumor planned for a surgical removal of thyroid gland. At what level of Cocker's transverse cervical incision is typically placed? So in the image given below, there were two lines, and the correct option was below 1 centimeter below the B line. So the A line represented the thyroid cartilage, whereas the B line represented the cricoid cartilage. And the incision is given 1 centimeter below the cricoid cartilage. What we are asked here is differentiate true parathyroid from false positive thyroid uptakes. In a study evaluating parathyroid function, some participants demonstrated uptake on a sestamibi scan but lacked other clinical or biochemical signs of hyperparathyroidism. Further evaluation revealed that these cases were actually due to Hurther cell carcinoma, Hurther cell thyroid nodules. Which of the following nuclear medicine tracers can help differentiate true parathyroid from false positive thyroid uptakes? So for thyroid, the molecule we use is technetium-99 protectinate scan and not the other molecules. Which of the following is the most common site for pill-induced esophagitis? Now, again, this is a very interesting concept. So in esophagus, we have constriction at mainly 3 points. The first one is at the pharyngoesophageal junction. The second, anatomists will see as two separate, but surgeons will usually see a single constriction. One is due to the left bronchus and other is due to the arch of aorta. So at this point where the arch of aorta crosses the esophagus, there is a compression, and the lowermost compression is due to the gastroesophageal junction. So pill-induced esophagitis is mainly due to the middle constriction. So mid-esophageal at the level of the arch of aorta will be the correct answer. Now, the pill-induced esophagitis is classically seen with drugs such as bisphosphonates. So it's always recommended to have a full glass of water along with bisphosphonates and not to lie down immediately after having the bisphosphonate tablets. Question 180. 45-year-old woman reports excessive thirst, frequent urination, fatigue, and slow healing of minor skin cuts. She also has recurrent vulvovaginal candidiasis. Which of the following metabolic state best explains this presentation? This is a classical presentation for diabetes. Chronic hyperglycemia due to insulin resistance, it seems correct. Thyrotoxicosis, no. Adrenal insufficiency, again, no. Diabetes insipidus, causing polyuria and polydipsia, it will explain the frequent urination, but not the delayed wound healing and the recurrent vulvovaginal candidiasis, which is seen due to higher amount of glucose in the body, uncontrolled diabetes. So option 1 is the correct answer here. During onset of intense physical activity, severe circulatory adjustment occur to maintain adequate tissue perfusion. Which of the following statement is true regarding these changes? Okay, let's analyze the option. Cardiac output increases primarily due to rise in heart rate alone. This makes it a false statement. Mean systemic filling pressure increases due to enhanced venous return. This seems to be correct. That directly produces this second receptor is adenyl cyclase. It increases the cyclic AMP, which is responsible for phosphorylation of glycogen phosphorylase, which causes glycogen breakdown. A 40-year-old man from rural South America presents with progressive dysphagia to solids, liquids, and chronic constipation. So we are seeing a megaesophagus, megacolon, and also a history of South America. Image is shown below. So it had shown a bird's beak appearance of the esophagus. What is the mechanism for this esophageal disease? Degeneration of nitric oxide producing neurons, autoimmune destruction of inhibitory neurons, destruction of the myelinic plexus, and smooth muscle fibrosis. Now here it is secondary due to the Chagas disease. If it would have been the primary disease, it would have been autoimmune destructions of the inhibitory neurons producing nitric oxide and VIP to relax the esophagus. So here the correct option is option 3. It is a case of secondary megaesophagus or secondary achalasia cardia. Question 184, 35-year-old woman present with resistant hypertension despite 3 antihypertensive, out of which one should be a diuretic, right? Her serum potassium is 2.7, so hypokalemia. There is no history of diuretic use. Okay, strange, because before calling a patient resistant hypertensive, there should be at least trial of one diuretic. But anyways, let's read forward. Which of the following is the most appropriate initial investigation? So in case of hypokalemia, what we are suspecting here in resistant hypertension is a Conn syndrome. So in Conn syndrome, to first screen the patient, we will always use plasma aldosterone renin ratio. That would be the most appropriate initial investigation. Question 185. 22-year-old man with type 1 diabetes mellitus treated with NPH insulin twice a day, regular insulin 30 minutes before the meals. His glucose log shows postprandial hyperglycemia 1 hour after the meal, followed by hyperglycemia, followed by hypoglycemia 3 to 4 hours later. His HbA1c is 7.9. His mealtime insulin is switched to insulin Lispro. Based on the pharmacokinetics, when does the peak hypoglycemic effect occur after the injection? Basically, we are asked about the time when Lispro will show its maximum action. And the time when Lispro will show the maximum action is half an hour to 1.5 hours. It's an intermediate acting, it's a rapidly acting insulin which will show its effect in just 30 minutes to 1.5 hours. Question 186. A 60-year-old woman has a hard 4 cm breast lump with pearly orange skin changes. Which of the following investigation of choice to confirm the diagnosis and obtain receptor status? Now, if this point hadn't been there, we could go for a FNAC, but for the receptor status, we need to have a true cut biopsy. Excisional biopsy is seen when we don't have enough number of cells in a true cut biopsy, but the investigation of choice to confirm the diagnosis will always remain a true cut biopsy. Which factor aids the most in disease elimination? Now let's take an example. In the COVID-19 pandemic, what was the reason that COVID-19 rapidly declined after a point of time? It was not due to isolation, it was not due to quarantine. Even when isolation and quarantine were practiced, the COVID cases still kept on rising. The major determinant on why COVID-19 cases fell was development of herd immunity. The development of herd immunity is the most important factor in disease elimination. Now, what is the difference between isolation and quarantine? In COVID-19, we all were quarantined. But did we have the disease? No, we did not have the disease. So quarantine is done for healthy individuals, whereas isolation is done for the cases. Surveillance may be active or passive, depending on whether the patient is seeking the healthcare worker or the healthcare worker is seeking the patient. The correct option would be herd immunity. In randomized controlled trial, the incidence of outcome of a new drug group is 11% and the placebo group is 12%. Which of the following what are the absolute risk reduction and relative risk reduction respectively? Now, how I will approach this problem is, we are asked about absolute risk reduction. So for new drug, it is 11. For old drug, it was 12. So absolute reduction is 1%. So I could eliminate option 3 and option 4, correct? And relative risk reduction. So without going into the formula, just by applying common sense, there is 1% reduction from 1% reduction, and now the new incidence is 11%. So there is 1% out of those 11%. So this roughly translates to 10%.
So the relative risk reduction is 10%. So basically what we are trying to say is that first it was 12, now it is reduced to 11. So the percentage reduction is close to 10%, whereas the absolute number is 1%. 8-year-old girl got to the clinic with complaints of vaginal bleeding and progressive breast enlargement over the past few months. Examination reveals Tanner stage 3B and pubic hair. You suspect precocious puberty. Which of the following condition is not known to cause precocious puberty? McCune hybrid is classically associated with precocious puberty, along with Scaphola macules and polyostotic bone disease. Hypothalamic hamartoma, which presents with gelastic seizures of laughing spells, it is also associated with precocious puberty. Severe primary hypothyroidism. Now, interestingly, hypothyroidism will cause reflex feedback to increase the TSH, and TSH will cause increase in LH and FSH in higher amounts. That's why we can see precocious puberty also in patients with severe primary hypothyroidism. If it was secondary hypothyroidism, it would be defect in TSH, and in secondary hypothyroidism, we wouldn't see precocious puberty. So the answer here is Prader-Willi syndrome, which is an imprinting defect in which the paternal gene is deleted and the maternal gene shows imprinting chromosome 15. The conversion of glyceraldehyde 3-phosphate to 1,3-bisphosphoglycerate involves the addition of. So basically, this is a substrate level phosphorylation, and it shows addition of inorganic phosphate. Just a fact from glycolysis. Which of the following laboratory methods is used to provide direct quantitative value of minimum inhibitory concentration for an antimicrobial agent? Kirby Bowles is a qualitative. I don't know about Stokes and Nagler's, but it doesn't. I know about Nagler's, but I don't know about Stokes method, but it doesn't matter because epsilon meter is a quantitative measure of minimum inhibitory concentration. So option 2 would be the answer. Which of the following anatomical structures is not related to the pyramidal eminence of the middle ear? Okay, so let's see. Facial nerve, sinus tympani, tendon of stapedius muscle, and oval window. Now, can you find the odd one out of these options? These three structures are situated on the posterior wall, whereas oval window is situated on the medial wall. So oval window happens to be the structure which is not related to pyramidal eminence. The facial nerve, especially the vertical segment, is on the posterior side. Sinus tympani, which is the space in which the ear disease is retained because it is present behind the pyramid. And the tendon of stapedius also arises from this very structure. 10-month-old infant presents with high-grade fever, incessant cry, ear pulling. Below is the image of the otoscopic examination of the ear. Which of the following organism is most likely responsible for this presentation? So as we can see, this is a case of otitis media, right? Most probably CS1. In CS1, the most common organism is strep pneumoniae. Even without the image, we could come at a diagnosis, and we could identify the most common organism. 12-year-old boy with a history of frequent sugary drink consumption presents with the findings shown below. Gram-positive alpha-hemolytic cocci producing extracellular polysaccharides are isolated from the plant. Which of the primary mechanism by which these bacteria causes dental caries? Acid production from the carbohydrate metabolism demineralizing enamel sounds correct. Secretion of hyaluronidase to digest the tooth protein matrix is incorrect. Direct invasion incorrect. Inhibition of salivary flow is again incorrect. Even if you have not read this in your medicine, you might be seeing these advertisements in which they show that having sugary drinks can be metabolized by the oral flora and the oral microbiome and convert into acid, and that acid is responsible for demineralization of the enamel. And the organism mostly is strep mutans, which is involved in these pathology. Question 195, electron microscope of a glandular cell is shown. Structures marked label A most likely represent which of the following? So there was a glandular cell and there were small granules which were there in the cell. Now, without seeing the image, just by knowing that it's a glandular cell and it will provide, it is a gland and it will secrete, it's a secretion, we could easily come to a conclusion that it might have been secretory vesicles, because only the glandular cells will show presence of secretory vesicles, whereas ribosomes, lysozymes, and mitochondria would be in every cell. Two no fiber samples are examined under microscope. Identify the correct classification of these fibers. Again, it was an image-based question and two fibers were shown. The first one was just the nerve fiber, whereas the second one had a myelin sheath coating around it. So basically, the first one was a non-myelinated and the second one was a myelinated nerve fiber. And as we know, the speed of conduction, the solitary conduction is faster in the myelinated one due to the presence of myelin sheath and the nodes of Ranvier. 18-year-old patient undergoes refraction after pharmacological dilatation using tropicamide, a drug that affects the structure within the ciliary body. Which of the following statement about the ciliary body is false? It is roughly triangular in shape in cross-section. It is again one of the correct reason. It contains approximately 30 to 40 ciliary process. This I'm not sure about. Its epithelium is derived from the anterior part of the optic cup. Again, it sounds to be a true statement because ciliary body is present in the anterior part of the globe. Pars plana is located 4 to 4.5 mm posterior to the limbus. This is also a correct statement. The clinical application is whenever we want to enter into the vitreous, we will puncture the eye 4 to 4.5 mm behind the posterior limbus to enter through the pars plana. As the pars plana is a relatively avascular zone, so even if I was not knowing the option, I could rule out the other option and arrive at the correct option. The diagram below shows the nuclei of thalamus in superior aspect and the coronal section. A structure labeled X is indicated. Identify the marked structure. So basically, the structure X was inside of the thalamus and in between the thalamic nuclei, suggesting internal medullary lamina. The external medullary lamina would be on outside of the thalamus, whereas the reticular nucleus and zona increta would also be on the outside or on the nucleus embedded, but it would not be on the inner surface of the thalamus. 199 question, which statement best describes the Stiles-Crawford effect? Again, these type of questions, it is advisable that you leave in the exam because these are just like random facts. And mostly, again, Ofthel is notorious for asking these facts. So let's read the option and see if we could eliminate any option. Light entering near the pupil center is more effective than the peripheral light. This is correct, as the light which enters in the pupil straight directly, it will go and directly go into the optic disc, whereas the light which enters peripherally, it will go into the other parts of retina, not providing enough illumination. Peripheral retina's low photoreceptor density, again that is correct. Peripheral corneal rays are blocked by the iris, again that is correct. The perpendicular rays will be blocked. Lens nucleus has a higher refractive index in the cortex. Again, that's a correct statement. Now, these three seem to be a facts rather than an effect, right? Option one seems to be that it is some sort of effect and not just a random fact. So by the gut instinct, I would mark option one. Okay, so the last question of the day, the diagram labeled A to E depict focusing of parallel light rays in various refractive states of the eye. Match each diagram to the corresponding type of refractive error. So, okay, we will draw it. We don't have the diagram. So what will happen in simple myopic is the rays would just converge in front of the retina. What would happen in simple hypermetropic is it would converge behind the retina. In compound myopic, both the rays would converge
in front of the retina. Similarly, in compound hypermetropic, all the rays will converge behind the retina. Whereas in case of mixed astigmatism, some of the rays would converge in front of the retina, while some will converge behind the retina. So these were the images, and you just had to match the following, and the correct answer was option 1. So with that, we come to the end of the target test discussion 3. I hope you enjoyed the session. I hope you learned some new things, how to eliminate option, how to derive an answer from the units and not from the content itself. And I hope it was a fruitful session to all of you. So keep solving MCQs. The more MCQs you solve, the more sense of how to eliminate option you will develop. And if you have any feedback or any comments on the session, you could either reach me out on Instagram or my mail. So I would love to hear out from you the feedback of the session. And once again, kudos to you for sitting here for the whole session, and kudos to the PrepLadder team to organize such a good initiative of the GD review. So I think that's it for the session. If you have any doubt, you can say it in the chat, or we can just end the session.